Realize.
Very good evening to one and all of you. Look forward to yet another very interesting ARC webinar, and this time on Retinal Brahmaastra. And this is going to be packed with medical and surgical cases, controversies, debates, a lot of fire in the air, and it's going to be beautifully steered by the absolute proponents of retinal surgeries from our country. We have on our expert panel Dr. Mahesh Shanmugam, who heads the Vitreoretina and Ocular Oncology Services at Shankara Eye Society based at Bangalore. Joining us soon is going to be Dr. Hemant Murthy, who is again the medical director of the Retina Institute of Karnataka and a very prominent part of the Eye Foundation group of hospitals. We have with us Dr. Unni Krishnan, who's the medical director and senior consultant, Vitreoretina Services, Neuro-Ophthalmology and Electrodiagnostics from Chaitanya Eye Institute and Research Center. We have with us Dr. Ajay Arora, who is the executive director, Vitreoretina consultant from Vision Plus Eye Center, and of course, a very eminent national figure, our joint treasurer of AIOS. Moderating with me is the very dynamic Dr. Srinivas Joshi, who's a member ARC South, but he's not just that, he's one of the directors of Joshi Group of Hospitals and is a very versatile, prolific surgeon and has done immensely for his institute and also for ARC. And without wasting any time, we shall go on to all those wonderful speakers we have on our session. Each of these talks are going to be of 4 minutes, followed by discussion moderated by the moderators, and discussions to be steered very briskly so that we're able to do good justice to all the medical and retinal cases and, of course, the interesting debates. Our first speaker is going to be Dr. Chaitra Jayadev, who heads the Retina Department of Narayan Nethralaya Group of Hospitals based at Bangalore. And she needs no introduction, an amazing personality, known nationally, and is also our joint secretary of AIOS. And she is going to talk to us on a very quintessential topic, PEDs. On to you, Dr. Chaitra.
Thank you, ma'am, for the opportunity. Always a pleasure to be part of ARC events. Today, I'm going to be speaking on the dreaded PEDs. Should we defend it or is it a dead end? I have no financial disclosures. So this is a 46-year-old gentleman, a very anxious patient. He had lost one of his eyes to a retinal detachment and then a failed surgery after that. He came to us with 6/6 vision, but he did have metamorphopsia for the past 3 months. This was in 2018. You can see the PED here. What you should notice is that there is some amount of hyperreflectivity intraretinally and also at the dome of the PED in the second image as shown by the yellow arrows. You can also see thinning at the margins of the PED here in the third image, and some pachychoroid was evident here. So we went ahead, and since he had some symptoms of metamorphopsia and he was a one-eyed patient, we were also, anxious along with him. We decided to go along with epinephrine alone for about 4 months. He had no change in the morphology or symptoms. So this is the PED there. After treatment for 4 months, we kept following him up. Of course, there was absolutely no change. And he still had metamorphopsia despite that. And then he was lost for follow-up for about 2 years. He didn't come back. And then he came back with worsening of vision at 6/9. And also there was increased metamorphopsia. He had received 2 anti-VEGF injections elsewhere with no response, either on the scans itself or symptomatology. So this is how he presented to us when he came 2 years later. There was a thinning of the PED at the margins. And if you can see at the dome of the PED also, there is some amount of thinning. There it's pointed out by the arrows there. You can also see intraretinal fluid and subretinal fluid, and you can see hypertransmission in the choroid as well. So that's when we went ahead and we did the OCTA as well. This is in September 2020. Yeah, and in October 2020 as well. This is when we decided, based on the fluid that was present, we decided to go ahead and give this patient an aflibercept. This was in December 2020. You can see that some amount of the subretinal fluid has come down, but the intraretinal fluid persisted. Then again, we repeated the injection, and this was in Jan 2021. You can see there a semblance of a neovascular complex on the octa as well. There was variable response to the first two aflibercepts. SRF was the first to respond, and intraretinal fluid and the PD remained same even after 2 injections. Blowouts of the RP was more actually defined on resolution, as you can see in the last image. This is in March 2021. You can see that the PED has flattened out even more. We still persisted, and by April 2021, you can see, great resolution except for the blowout that you see. This was in May 21. There was further remodeling, and the patient symptomatology also got so much better. This was in July 21, and the last follow-up in August 21. 2 months later, they were, after an injection-free period of almost 5 months, the patient presented to us with again a little bit of recurrence. This was in October 21. Almost 5 years, we had not treated, 5 months, we had not treated the patient, but you can see that there is some amount of recurrence there. So metamorphopsia, recurrent serous PED, one-eyed patient, you can see some changes on the octa as well. So some points that we could probably ponder in this particular case is what are the management options for these patients with serous foveal PEDs with early symptoms? What works best for them? Does eplenorol have a role at all? What about aflibercept? How do you manage recurrences? Should we go back to treating this patient with anti-VEGF? And pachyneovasculopathy, what are the options for treatment other than what we've done for this particular case? Thank you so much.
Thank you, Dr. Chaitra. That was a wonderful case and questions posed. So, Srinivas.
Yeah, I think good case presentation. I just wanted to ask, was the angiography, FFA or ICG done in this case, Dr. Chaitra? And what was your initial diagnosis to look at? It looked like a CSR, what you started with? Or?
So not really. It didn't have a classical, CSR picture, right? It only had a PED to begin with metamorphopsia. So at that point of time, when he came in the first visit, we really didn't do anything.
So because you started them on eplenorol for
yes.
Nearly around 4 months. So what was in your mind before starting that?
We were preempting probably an occurrence of a CSCR. I'm not sure, Srinivas. The only reason why we gave him that was because he was symptomatic and he was a one-eyed patient. There was no CSR at the first visit. It was just a serous PED. And you see there was no intraretinal fluid, no subretinal fluid, nothing was there in the first visit. Since he was also very anxious, we thought maybe we can preempt the occurrence of anything, going further, maybe even occurrence of a CSCR. We were not sure. So we just, we were monitoring his electrolytes also every 2 months. And then after 4 months, he stopped coming. And luckily, he had stopped the eplenorol as well. So at the first instance, we didn't do the angiography.
Good. Yes, Dr. Unni.
Okay, so thank you. That was a really nice case, Chaitra. So basically, rather than struggling to diagnose CNVMs, we sometimes struggle not to diagnose CNVMs. So here we have a serous PED, and this particular, the nature of the progression of the disease has been described in a particular condition or sequence called RP aperture. RP apertures are very thin-walled PED, serous PEDs with extreme thinning of the RP on top of it, which can cause overlying intraocular fluid changes in the absence of an active CNVM. So points favoring an active CNVM would be rapid expansion of the PED and sub-RP material. In the absence of that, this could very well categorize as being this condition called RP apertures, which is thinning associated with micro ribs, sometimes at the base, sometimes at the tip of the PED. One interesting point is that on the OCT, you have got semblance of vascular membranes. But if you look carefully, some of the things you have, the slabs or the choriocapillary slab in which you don't expect the CNVM to be at that point. So the semblance of a vascular network can occur when there's extreme RP thinning, and you get a false artifactual vascular network. Now, the use of aflibercept is probably to reduce the pachychoroid that you found, and whether that had an indirect effect in reducing the PED, and subsequently the disease came out. But typically in RP apertures, they end up in well circumscribed, delineated areas of RP atrophy.
Atrophy,
so,
yes.
Yeah.
So luckily, I think the atrophy would have probably been larger had we not intervened. I'm not sure, but if you see that it's still a very, focal area of atrophy that you can see with the backscattering. So it was not as wide. So the patient still retained a decent amount of vision.
MPS sir and Hemant sir, quickly, and I want to add one along with your comments to ask one question. What's the maximum time limit where we can use this eplerenone? Because now it has been rampantly used, and when we can say that, okay, now we have to stop and this is not working anymore. Like how we try the 3 monthly doses of anti-VEGF and then we say if it's not, then we switch it. So what's the dose for, just for the interest of the ophthalmologist here to know for the usage of eplerenone? MPS sir?
I have used eplerenone for months together or years together if it is responding. So if the patient is responding at a chronic CSC and there is nothing else we can do. So we have placed the patient on even a couple of years or 3 years also, telling them about the complications as well as periodically monitoring their electrolyte imbalance if they are not going to be on electrolyte imbalance. So it is reasonably safe and it doesn't work in all the patients. It works in a subgroup of patients. So I have had patients on years together on eplerenone as well.
And
I think if I can, Srinivas, if I can take it, one of the points about this is I heard in an international symposium is that the minimum duration should be at least 2 months to say that eplerenone is not working. That is at least 2 months. You cannot say that it doesn't work unless you give it for 2 months is what I heard in another symposium.
Chaitra, can I make a point on your first slide? If
Yeah.
you look on the top left photograph, you had a sliver of fluid present next to the, the hyperreflective material, which you said.
Yeah.
So if I was in this thing, I would have probably also done a fundus autofluorescence, which may have actually helped in the RP aperture, as well as doing an FAICG. So that would probably help us in the long run, because having a presumed diagnosis of CSR, I'm not sure if that is because an autofluorescence might tell us a past history evidence of CSR.
In your patient, the patient presented with PED, right? He did not have any signs of CSR.
Nothing at all, sir.
Nothing at all. So he just had PED.
And
I would treat it
metamorphosia.
as, I would treat it just as serous PED, and as what Unni has mentioned, what you had seen was an RPE aperture that was there that was causing those changes that you observed on your OCT. And that is what has led to an atrophy, which you see in the later stages. I'm not sure whether aflibercept did anything for the patient or was it the natural course. I'm not sure.
That was much later, sir. We gave aflibercept when the patient developed fluid, subretinal, intraretinal fluid. It's only then that we gave, not at the first visit. We never gave.
That was ICG proven.
No. Octa proven, sir. Based on the Octa, I think they also.
Yeah, we saw complex, and actually it responded. The intraretinal fluid, subretinal fluid, all of it went, and the PUD completely flattened.
So you can call it a hastened natural progression of the disease.
This is for only.
No, but will you wait for natural progression when you have one eye young patient, sir?
Yeah, but then there is a recurrence. There is a recurrence once you stop the aflibercept as well, isn't it?
Yes, sir. So that means it had responded to it.
Yeah, sorry, that again indicates it's probably a network, right?
Yeah.
So the recurrence is probably the indicator. Then that's it.
No, but what about intraretinal fluid, sir, and subretinal fluid? You just wait for it to naturally go away?
That was what you're talking about. Fluid is at the apex of the PED and one at the.
Yeah, right at the base of the PED, there was subretinal fluid, and at the apex of the PED, there was intraretinal fluid.
But that has
that time, did you do an ICG?
No, sir, we didn't do the ICG. No, the second time we did an ICG, it didn't pick up anything.
No, it didn't pick up anything.
So, Srinivas, shall we go on to our next speaker with a lot of questions left unanswered?
Thank you so much, ma'am.
PEDs are always a dilemma, so I think, yeah.
That's why I don't defend or dead end. Thank you so much. Thanks.
Nice.
So we shall now go on to our next speaker, Dr. Vivek Dave, who's a senior vitreoretina consultant from LVPI Hyderabad. Again, a very dynamic, prolific surgeon. And he is going to be telling us about pre-macular hemorrhage, usual presentation and unusual cause. On to you, doctor.
Thank you, Dr. Chitra. I hope my slides, the slide is visible.
Yes.
Yes, yes, Dr. Vivek, go ahead.
All right. Thank you. Thank you, Dr. Chitra. Thank you, Dr. Srinivas, for having me in this august company. I'll quickly go to my case titled Pre-macular hemorrhage, usual presentation and unusual cause. This was a 45-year-old female, spontaneous onset loss of vision in the right eye. Presenting vision was counting fingers 2 meters. As far as the systemic history was concerned, she was a well-controlled diabetic. Had a recent history of dry cough, a few of them very explosive episodes in her language. This is what the right eye looked like. If we see, the media in general was clear, but right at the posterior pole, you can see this blob of pre-macular hemorrhage. It is covering the blood vessels, indicating that it is pre-macular in location. Few hemorrhages here and there in the rest of the retina, which in the initial evaluation, I felt possibly is a background diabetic retinopathy. At 10 o'clock, I could see one area which was not that hemorrhagic. Possibly in hindsight, once we go ahead, I would say in hindsight, this looked as if this was a point lesion there, which I could not characterize at that point in time. This is what the other eye was. She had some amount of cataract, plus the fundus photo actually is not well focused. There were few exudates temporal to the fovea, and rest of the retina otherwise was unremarkable. Coming back to the right eye, the optical coherence tomography showed a clear vitreous cavity. You can see a well circumscribed hyperreflectivity corresponding to the premacular hemorrhage visible here on the OCT. There is some amount of backshadowing because of the hemorrhage, but if we look here, we can largely trace the retina below the hemorrhage. And to me, this seemed to be possibly largely a normal looking retina. Just keep a lookout for these layers which are dipping here. Initially, I had missed this. This again for me is retrospective or hindsight sort of input. The other eye OCT unfortunately was missed at that visit. Suspecting that there was also a diabetic retinopathy which I couldn't pick up clinically, I did an angiogram. The angiogram did have some sort of block fluorescences due to some hemorrhages, but no real microaneurysms. At the posterior pole, again a blocked fluorescence because of this premacular hemorrhage. And like I told you, around 10 o'clock, 11 o'clock, some sort of a saccular lesion which largely did not leak in the further frames either. The other eye, though, showed the hyperfluorescence very characteristic of a macular or a parafoveal telangiectasia. So what did we have here? Definitely a left eye macular telangiectasia. In the right eye, a sub-ILM hemorrhage, possibly due to a Valsalva retinopathy with an underlying macular telangiectasia, or was it purely due to the macular telangiectasia? This was something that I could not characterize at this point. But with her having had vision loss and a significant looking lesion at the posterior pole, she was advised for a right eye vitrectomy with ILM peeling. Now, I will just run through this video quickly because nothing unusual in the video. Dye-assisted PVD induction, and after the PVD was induced, I stained the ILM with brilliant blue G as we normally would do, and go ahead and then peel the internal limiting membrane. After the ILM was peeled, the residual hemorrhage, as we can see, the location was premacular sub-ILM, and this was cleared out using the cutter and a flute needle. Now, as I'm clearing off the end of the hemorrhage, you can see the edge of the telangiectasia was bleeding. I had to raise the bottle height and stay there for some amount of time, and then the hemorrhage finally stopped. So this was the macular telangiectatic vessel, which actually had opened up and was bleeding. That is what caused accumulation of hemorrhage in the sub-ILM space. The retina looked fine in the post-op, confirming the diagnosis of macular telangiectasia. OCT angiogram again confirming the diagnosis. So also in the other eye, you can see the outer retinal defect there. I went back to literature. I could only find this one case series of 3 eyes where a pre-retinal hemorrhage was shown as the presenting sign of an idiopathic macular telangiectasia. So the intrigue for me and for the panel, I would like to put up have you seen macular telangiectasia present with a premacular hemorrhage like this? Going by her history, was it a Valsalva phenomenon that possibly superimposed on the macular telangiectasia and caused it to bleed? Again, the case series that I allude to, 2 out of 3 cases again had a lot of history of cough, and one of those cases was on an anticoagulant. And if the telangiectasia would bleed and you would find something like this on table, would you go ahead and cauterize it? I was very tempted to cauterize that bleeder. At the last moment, I decided not to cauterize, just raise the bottle height and sit and wait and look for it to close down. And luckily, it did close down. So open for the panel and audience if you would have had an experience of a case like this. Thank you.
That was a wonderful presentation, Dr. Vivek. So let's hear.
Thank you, Dr. Vivek. That was a really interesting case. Hemant sir, when he showed the first OCT, in fact, we could see the foveal depression also in that. In fact, it definitely looked like a premacular. That means it probably looked like a sub-hyaloid kind
Sub-hyaloid.
Sub-hyaloid. But when he went inside, then it clearly, after doing a PVD also, it looked like a sub-ILM bleed. So how do we distinguish this? Because sometimes, because there is a clear space I do see in that OCT, we can see that foveal dip also and everything, but it turned out to be a sub-ILM. And in these cases of sub-ILM, how early we have to remove these sub-ILM bleeds before it causes any damage or any toxicity initially for initial discussion?
No, the OCT, probably I would do it at the top end of the hemorrhage, because that is wherein you might get some evidence of finding out whether it is sub-hyaloid or sub-ILM, because there would be some serous component as the patient is sitting up. I think that's the place where we can make out. But this was a clearly sub-ILM hemorrhage as seen on surgery. So I think there is no doubt in this. There is already a proof of that. But the only thing that I found interesting is I feel that there is a venous occlusion that you see post-op. If you see a post-op photograph, the superior temporal vein appears occluded. Because if you observe that, that seems to also have been a factor probably triggering this response in the macular telangiectasia. I just want to know that,
Can I
and
make
also
a comment,
some
please?
splinter hemorrhages were seen along with that, Dr. Vivek.
So can I make a comment, please?
None of, for the want of time, I did not put more slides, but on the angiogram, none of the relatively large vessels sort of, fluoresced. So in a vein occlusion, possibly you would expect that. But then again, yes, those hemorrhages were there. That was the first thing that prompted me actually to do the angiogram. Otherwise, I might have just stuck with the OCT.
Yes, Dr. Unni and then Dr. Guha.
Okay, so I just wanted to make 2 comments. The possibility of having a pre-retinal hemorrhage with MACTEL happens when there is an epiretinal neovascularization, which has been well described by Dr. Ayachit. So one thing is that, there are a few case reports where there is a diabetic retinopathy in which the vessels have grown into the macular telangiectasic area. Here you also have a vasculopathy. There is definitely a retinal venous occlusion. Even the first picture, the flow pattern in the FFA, the first picture there, and the hemorrhage is only in the superior part of the macula. So there is definitely a component of some amount of vascular occlusion, but explaining it could be an independent Valsalva, but a Valsalva at that location with a MACTEL could be, and the intense fluorescence on the FFA, you get it at a single point. All these could be leading to the diagnosis of an epiretinal neovascularization component of a MACTEL in the right eye.
Yeah.
Yes,
So,
Dr. Guha.
yeah. So wonderful video, Vivek, and quick comment on the technique. I won't dare to go when I'm working near the fovea with a blunt tip. I thought you were using a blunt tip. So number one. Number two, I feel from my experience that there could be a possibility of a concomitant. As Uni was saying, it could be related nuclear vascularization, neovascularization, but concomitant macroaneurysm, because those features were very typical, what I would call a macroaneurysm coexistent, or as a result of a previous BRVO. So, and definitely no cautery to stop the bleeder. At the best, what I usually do for the disc bleeders, Professor Eckhart has shown long back that if you just raise the pressure or and put a diamond dusted DDMS and press over it for 1 or 2 minutes, it just closes on its own. Thanks.
And I also feel that using a PFO is less invasive as compared to using any instruments. It really works well.
PFO sometimes.
Yeah. MPS, sir, please, last.
Yeah, I would agree with Dr. Unni, because like it does look like the fact that it bled during the surgery probably indicates there was an epiretinal neovascularization. We have had a couple of patients, and usually it bleeds when the PVD occurs. So the Valsalva could have prompted a PVD at the macula, which could have given rise to pre-retinal hemorrhage as well. And the initial color photograph also shows the supratemporal vein to be dilated with the hemorrhages, indicating probably patient had a supratemporal branchial vein occlusion, which was partial and which was evolving as well.
Thank you.
Thank you for the comments.
Wonderful presentation. We shall now go on to our next speaker, Dr. Manoj Khatri, who's a senior chief of vitreoretina services at Rajan Eye Care Hospital, and also the founder and managing director of iDocs Eye Hospital, Chennai. And he is going to be talking on serous macular detachments and common causes.
Good evening, everyone. Are my slides visible and I'm audible?
Yeah.
Okay.
Yes.
So the topic what I'm discussing today is uncommon causes of serous macular detachments, no financial disclosures. Why this thought came to mind is our glaucoma colleagues who are widely using prostaglandin analogs, they were asking a question like, do we need to assess retina in a better way before starting these patients on PGA analogs after having a couple of cases, which I'm going to share? And if there is any relevance of pachychoroid spectrum, which is of a flavor of the season for all retina colleagues world over, is there any cause and effect relationship? So just going to the patients directly, patient had a primary open angle glaucoma with a 0.9 cupping, and pre-treatment, though I don't have a photograph of the retina, but pre-treatment was fine according to the glaucoma colleagues. And after about say 6 weeks, came with a drop in vision, which was not very significant. But the patient said, I have some kind of a metamorphosis, and if you carefully look, there are kind of a extrafoveal serous macular detachments in both the eyes. Though intraocular pressure was fairly well controlled, the further multimodal imaging confirmed the diagnosis, and we saw this kind of serous macular detachments. In these patients, it was extrafoveal in nature. But we went ahead, investigated this patient further, showed a CSR type of a leak. We were quite doubtful because there was no significant contributory history of CSR pre-existing. So unlikely this patient had a CSR to start with. We were just contemplating and just kept this patient under observation and shifted from prostaglandin analogs to timolol maleate. And over a period of time, within a span about from 2 weeks to 2 months, the entire fluid absorbed. And that, make us think that are we missing out something in these patients? And over a period of time, what you see here in this clinical picture, the entire fluid disappeared and the patient did quite well without doing any further investigation. We thought this was just one of the case. This has been happening for the last almost 3 years now. Another patient, a female patient with a primary angle closure disease post-YAC PI, came with a drop in vision with a presentation like this. No brainer here. It looks like a typical CSR with kind of a fibrin, which is significantly present there. But the recent history when we took this patient was started recently on prostaglandin analogs. There is a retinal dipping on the OCT confirming that this fibrin is there, and also there is a typical presentation of CSR. Now, what we thought is how to treat this patient. Do we take away the prostaglandins or we just continue it? FFA did show a juxtafoveal leak, typically showing the CSR pattern. The other eye also had similar presentation, but I'm just, because of lack of time, sharing only one eye. Over a period of time, we just shifted from prostaglandin analogs to timolol maleate combination. And what you can see here is a serious follow-up of these patients over a period of 3 months without doing any intervention. Though this PED remained here, but the foveal contour came back to normal, and this patient responded quite well to just an observation therapy. So we had some kind of a pachychoroid spectrum here. So we were thinking whether there is a hyperpermeability or hyperviscosity or a hypotensive effect due to PGA analog, which has led to progression of this CSR. The patient may had a subclinical CSR to start with, which was missed initially before starting the therapy, and so on. So these were the doubts. Another patient, again, primary angle closure disease, had a similar kind of a presentation, but here the fluid was just abutting the fovea and didn't require any further treatment apart from that observation and stoppage of prostaglandin analogs, and the fluid resolved completely. Now, this was a time when I thought, okay, let me dig deep into these things, and I went ahead, did literature search quite extensively. In literature, both topical and systemic prostaglandin analogs have known to cause this kind of a serous macular detachments. Though pachychoroid is still not widely documented, but there is some role of there is some role of pachychoroid spectrum as well. And we submitted our case series also under publication, which has been reviewed and accepted. And these are a couple of cases which I've taken from the publications, which showed even presence of cystoid macular edema, which can be due to the hyperviscosity state. And over a period of time, once we take away the prostaglandin analogs, it just resolves without any further treatment. So this was the thought process. I thought this will be some interesting cases here to discuss with this expert panel. However, we had certain limitations. To my knowledge, we didn't do ICG for any of the patients. EDI OCT was a limitation again. And repeat angiogram was not done because I thought like, it is not necessary in this, doing one more invasive test for this patient. But there were a lot of questions which were unanswered. A couple of them which I have enlisted here is this entity same as CSCR, or we are looking at something else? But angiography did show pinpoint leak. So we are dealing with some component of CSCR here. I'm sure we have asked a couple of other glaucoma colleagues also. Few of them have responded that they had similar experiences with prostaglandin analogs. Is this subretinal fluid is due to the effect on choroidal circulation or a hypertensive effect? We still don't have any answer for it. And should we be looking for anything else, before starting PGA analogs, because they are primary line of management in most of the glaucoma OPDs nowadays. And we definitely need to rule out other causes of CSR for any patient. So the take-home message is there is some role of pachychoroid. We still don't know what is the relevance, or we have to, do a couple of case series studies to know what is the significant relevance of this. SRF, according to literature and to our experience, can be due to hyperpermeability or a hypertensive effect. Both can cause either way. PGA analogs can cause subretinal fluid formation and should be looked for in uncommon causes of serous macular detachments. An early switch to other anti-glaucoma medications, especially non-PGA analogs based, will be helpful to avoid any undue treatment modalities. Thank you so very much for the opportunity and the patience here.
Thank you very much, Dr. Manoj, for bringing out interesting case. But in my time of working in glaucoma also, I have not had a single case scenario, although it does say that there could be an increased choroidal permeability. So it was interesting to know that you had 3 set of cases.
Yes, ma'am.
Yeah. Thank you. Dr. MPS, sir, are you there?
Yes, but I'm here.
Yeah, I just wanted to know your association with these kind of PGE analogs, whether this case, to start with, whether he was on the due course of CSCR and then the PGE analog kind of exaggerated the response, or whether it had no response at all and these two are individual entity. And I've also heard that in few of your cases of non-resistant CSCR, you have even tried the steroids like Ozurdex in these cases. So I just wanted to know your experience on these PGE analogs and usage of steroids in CSCR.
PGA analogs, yes, they have used it for like cystoid macular edema is known, and some cases are there of causing a subretinal fluid are also there. But the mechanism it works is it actually increases the transscleral flow. Actually, it's the fluid flow out of the eye rather than the choroidal congestion and fluid accumulation towards the retina. That is not how PGA analogs work. It is possible it may cause, because there are case reports, but it is possible it is just an association, because 2 of the cases which Dr. Manoj presented have had an acute attack as followed by YAG PI. So just case reports are there, but like Dr. Chitra mentioned, that there are like large number of patients which have been treated with PGA analogs without any such occurrence being noticed in a large number of patients. So I don't know. I think the jury is out. I have treated some of the patients with subretinal fluid, persistent subretinal fluid, post-buccal surgery or post-vitrectomy with PGA analogs, and found the subretinal fluid to decrease actually, in contrast to increasing. In CSCR, probably it may increase. I have no idea about that. Like I have not used PGA analogs in CSCR. As far as the steroid usage is concerned, I use steroids in association with anti-VEGF when it's a CSR associated with PCV. not in patients with CSR. So polypoid choroidal vasculopathy presenting with subretinal fluid and who is resistant to treatment, then I add steroids like Ozurdex and found the resolution to be better in some of these patients who are resistant to anti-VEGF agents.
Hemant sir, Dr. Unni.
Basically, I agree with Mahesh. Difficult to say because the basic mechanism that we know is in the other way. Whether really they were just associated, these cases had CSCR and their tendency for CSCR, and that's what triggered the whole response and resolved. It's difficult to say. But I think he has observed these in a series of cases, so I think it will be interesting.
That's a thought I have, sir. Actually, I was thinking the same. It should be other way around. But just with observation, these patients improved. So we were thinking, I was still thinking actually, what is the real cause for these patients developing serous macular detachment.
But they resolve with stopping the medication, no? So that's
yes,
there's a link.
Manoj, that means that in case people are using PJ analogs, then macula should be screened before the analogs are started.
That's what even glaucoma colleagues are asking now. So we are thinking, or any relevance of pachychoroid, because one patient did show pachychoroid spectrum as well. So whether we should screen some potential patients who are at risk of developing serous macular detachments, that will be, I think, the way to look forward.
Actually, the first patient you showed, after resolution, the left side, there is a small hard exudate at the level of the fluid.
Yes, sir.
Indicating or possibly the patient had a pachychoroid with the polyp somewhere there.
Yes, agree.
Could be. That's right.
Yes,
maybe giving a challenge test in these patients in whom the fluid has resolved. If you start analogs again and the fluid comes back again, then maybe we can establish cause and effect relationship. Till then, everything is, just an association, I guess.
Agree, totally agree with you.
Yeah. So that was good. Interesting case. We shall now go on to our next speaker, Dr. Navendu Rai, who's the director of the Navendu Eye Care Center from Deoria, Uttar Pradesh, and he's going to be talking on macular hole falling intravitreal injection.
A very good evening to all. At the outset, am I audible, ma'am?
Can you increase your volume?
Yes, Dr. Rai.
Yeah. At the outset, I would like to thank Chitra ma'am and Srinivas boss for giving me this opportunity to speak in front of this office gathering. And when Dr. Srinivas called me that we are going to have a retinal Brahmaastra, do you have a medical retina case for this Brahmaastra? I said, okay, I think I have an OCT finding which looks like the effect of a Brahmaastra. Brahmaastra has been, it has been related to nuclear weapons in our today's this thing. So I would be talking about the vaccine and waning macular following use of bevacizumab in diabetic macular edema. This was one case which I reported in 2014, and this was a 48-year-old male. He was diabetic and hypertensive for 15 years and had diminution of vision in both the eyes for 1 year. So this is his fundus photograph and his OCT findings involving a lot of cystoid macular edema and the subretinal fluid in that. And in both the eyes, he was given intravitreal Avastin in both the eyes. And to my surprise, in the left eye, I got this picture. Can you see the left eye? As if something is escaping from the, the SRF is trying to escape from the beneath the retina. So in the right eye, the second dose of Avastin was given and the fluid almost completely resolved. So the SRF completely resolved in right eye, and the left eye I plan to observe. And to my surprise, it resulted into a macular hole formation. Again, what happened next? In the right eye, a modified grid laser was done, and the patient's vision, it improved to 6/18 from plain counting. In the left eye, I kept the patient under observation, and as the edema again increased, again formation of cystoid macular edema was seen, and SRF accumulated again. The second dose of Avastin was given, and like in the after the first dose, the Brahmaastra effect of Avastin was seen. Similarly, in this again in the second dose, after the second dose also, after 2 weeks of giving Avastin, this Brahmaastra effect, it again came into existence, so as if something was escaping from the subretinal space into the vitreous cavity. And again, the macular hole was evident after 2 weeks of this Avastin. So what to do now? I had planned macular hole surgery. In this case, the macular hole, it resolved after ILM peeling, and the patient got some visual vision in the left eye also. So my questions for the panelists are: cause of macular hole in this post-Avastin case, and what is the hypothesis in etiology of this case, and experience with ILM peeling in such cases of the panelists, in such cases following, in diabetic patients with the macular edema leading to macular hole, and then after ILM peeling, what is your experience with ILM peeling in such cases? Thank you.
Thank you so much, Dr. Navendu. It was really an interesting case. Can you just stop your screen share? Dr. Unni, in the first OCT, when we looked like, was there a vitromacular traction? And because of the giving of anti-VEGF injection, that it caused a little bit more activity and it caused a macular hole is my first query in this case. Because I could see some vitreous getting attached to that and giving an anti-VEGF, because we have used gases, we have used many of the vitreous substitutes to cause these get away with these tractions. Although we don't have most of these agents which are available in the United States, but still we have used gas to see if we get off with VMT. But using an anti-VEGF agent in this caused this damage, and that caused the more traction and caused the hole in this case. Just your opinion on.
Yeah, so I have to be slightly speculative here. Even if you had injected saline, you might have got the same result just by the induction of a PVD. Yeah, if you can understand what I'm saying, that is, there's no way that we can prove that it is because of a particular anti-VEGF effect. But what we know is that a PVD has occurred, and the PVD has probably pulled out something. The first, I was trying to see whether I was trying to look at the first picture to see whether the hole was already there. It was filled by some extraneous tissue or something like that, or whether it was gliosis. Because if you look at the edges of the hole very carefully, you can see the ILM stopping short, the ELM stopping short at that particular point. So whether there was already, it was way into the formation of a hole, I am not sure. But anyway, the only thing I can say is that a PVD was induced. That is the only definitive thing you can probably say from that particular thing happening. Yeah, just an interesting thing. The last question Dr. Rai mentioned was, what is your experience in ILM peeling? So nowadays, you ask me the question, what is your experience in not peeling ILM? That would be a more definitive answer than what is your experience in peeling ILM. We peel it for each and everything partially indicated and probably illegal also.
Yeah, retinal surgeons are using it like an Avastin. Yeah. Kind of anti-VEGF. Hemant sir, your thought on this, please.
No, I would agree with it that it looked as if this had a VMT to start with, and the incidental that they just induced the PVD, caused the macular hole, and that is what would have been produced by this injection. So I don't think by giving this it has produced it. It's probably pre-existent, which got because of the PVD developed a macular hole. And I think that's how I would explain this situation.
I'd like to ask a question to Dr. MPS, sir. Sir, would the anti-VEGF drying effect of the CME at the edges cause the macular hole to be larger than a pretty large macular hole over there? Do you think that this anti-VEGF has actually caused a little bit of CME drying and a larger macular hole?
Difficult to say, but actually there are papers where they have said that a recurrent macular hole they've treated with NSAIDs and dorzolamide and found the hole to close. So that's a recent paper where they have used this as a treatment in smaller recurrent macular holes, and where the CME going away and the hole closing.
Yeah, so but when it is like this, sir, like a opened kind of bridge.
Well, the height is greater than the width it has been used.
And it tries to subside down and closing the bridge. But MPS, we have used most of these gases, airs, and most of these vitreous substitutes also in this vitromacular traction. But still, I just want to know whether giving this anti-VEGF agent has any specific cause, or it just acted like any of the other vitreous substitute that it just pulled off and caused the PVD and caused the macular.
Would there have been vitreous incarceration which causes these things?
So I think no, it's been well documented that if you give an anti-VEGF, and especially in cases where you have cystic spaces like this, Novendu's case had some cystic spaces, you can actually have a molar cell blowout within it, and it can cause a localized infarction, which has been indicated as a contributory factor for the macular hole resulting from injection of an anti-VEGF. So it is true that an injection of an anti-VEGF induced the PVD. I think, Novendu, you had 2 injections of anti-VEGF?
Yes, sir.
So after the first injection, your second slide showed that there was a vitreomacular traction.
Yes, sir.
You still persisted with the injection, so that actually went on with a macular hole formation. But it's possible that Avastin contributed to. That's what has been described in literature, that it can cause, especially if an ERM is present. Your case didn't show any ERM to my this thing. I'm not sure about that.
Fine ERM, sir. There is a very fine ERM in this case.
Okay.
Yes, sir.
Just one short comment, Srinivas.
Yes, sir.
Yeah, so I totally agree with what Ajay just said, but referring to MPS as small series, holes less than 250 micron or 200 micron have been shown because of the hydration effect to wear off by the use of those drugs as MPS has maintained. But these large holes don't close by those drugs. Only smaller holes would close by the hydration effect.
Thank you. We shall now go on to our next speaker, Dr. On the surgical cases. We'll start now, and we have Dr. Sangeet Mittal, who is a director and vitreoretina consultant from Model Town, Jalandhar, from Thind Hospital, and he's going to be talking on choroidal blowout.
Thank you, ma'am. Am I audible?
Yes.
So thank you, ma'am, and thank you, Srinivas, for giving me this opportunity. So as you told, I'll be speaking on a unique complication, that is a choroidal blowout during silicone oil removal. So my case is a 56 years female. This is 2 months post cataract surgery. She had underwent elsewhere. She came with the complaints of persistent pain and decrease of vision since 20 days post-operative. And she had undergone multiple intravitreal antibiotic injections elsewhere. So vitreous cavity was full of exudates and there was no view of fundus. We did a B scan and it revealed a total retinal detachment. And best corrected vision at this stage of the patient was PLPR accurate. I don't forget to mention that the other eye was blind due to trauma for the last 20 years. So we took up the patient for vitrectomy, and the removal of interior exudates was done. We cleared all the vitreous opacities and we saw that the retina was totally detached. So peeling of posterior hyaloid was done carefully. The whole of the hyaloid was removed. After the removal of the hyaloid, so there was thick membrane over the disc, overlying the disc, which led to a little bit of hemorrhage from the disc, but that was easily controlled by raising the infusion pressure. The whole of the hyaloid was removed, and then we did a fluid air exchange. We settled the retina, and then did an endo laser, and then we used silicone oil as a tamponade in this patient. So nothing untoward till this point, but 3 months the patient underwent a silicone oil removal, and you see during the silicone oil removal after the silicone oil removal, a free flow of fluid is being observed from the sclerotomies. So we thought there was a bit of epiretinal membrane here. We thought we removed the epiretinal membrane and we change it with the air inside. But as soon as we switched to air, we saw this thing happening. There was a choroidal detachment and there was air which had gone into the suprachoroidal space. And before I could realize anything, I saw these bubbles popping out from the suprachoroidal space into the vitreous cavity. I again checked whether my infusion cannula has slipped into the suprachoroidal space, but it was very much into the vitreous cavity still now. So we removed the air which has come into the vitreous cavity and checked there. There was still air present in the suprachoroidal space and it was still popping out. You can see these air bubbles coming out from the suprachoroidal space, rupturing the choroid and the retina. and the air bubbles were popping into the vitreous cavity. So at this moment, I was totally flabbergasted. I didn't know what to do, but then I thought, I cleared off the infusion cannula once again. And then I thought I'll just counter this air with more air from inside. I again switched to fluid air exchange. This time, thankfully, there was no suprachoroidal air infusion. We removed the air which was present into the suprachoroidal space using a 26 gauge needle. And once the retina was settled, we did endo laser around this rupture site. And again, we used silicone oil as a tamponade, and this time we did a direct silicone, did it under direct observation because I didn't want my oil to go into the suprachoroidal space. So this left me this was 1 year post-op. I did not dare to remove the oil again. The patient had a vision of counting figures at 1 meter, but there was still some membranes, but the patient was happy that she's seeing something. It left me wondered why this complication happened. So I just this is the why this can be explained by Newton's third law of motion, that every action has an equal and opposite reaction. So what actually happened was that inflammatory membranes, they form in ciliary body area in endophthalmitis, and some of fibers of these membranes, they do remain in front of infusion cannula. Also due to the endophthalmitis, we are not able to clear all these fibers during our first surgery. So these fibers do remain. And because fluid does not create enough force, it keeps on flowing through or on the sides of fibers. Air exerts a larger force on the fibers, and due to Newton's third law of motion, fibers exert an equal counterforce on the cannula, forcing it to slip backwards. And once the fibers are broken due to extensive force, the cannula returns to its normal position again. So this is what I thought was what has happened in this case. And the moral of the story is always clear the infusion cannula first. I think this is the first lesson we were taught when we were taught vitrectomy. But I think I overlooked this, and this resulted in a very bad complication. Thank you.
Fantastic, sir.
Fantastic.
Thank you for sharing such a complicated case with us, and really, it was really mind-blowing. I shouldn't say it as mind-blowing, but definitely it's a very challenging case.
Yeah, it's blue with a choroid actually.
Hemant sir, I just had one query. Although he has given a very good explanation for it, but could it be because of the use of the non-valved cannula that it might have caused the hypotony, and because of which there could have been a slippage of these infusion cannula, and the air might have gone through it, or whether these cases could have happened even in the valved cannula? Does valved and non-valved cannula have any role to play in these the air to go into the choroidal space?
No, see here what I agree with it. See, if there is some tissue in front of the infusion cannula, that is why the cannula tends to slip, and because of the force of the air or fluid. Generally, fluid doesn't cause a problem, air does. And whenever that tends to slip, it has gone to suprachoroidal space. The only change I would have done is I would have changed the air cannula to the other side and gone ahead rather than persisting with that side, because then the air, you will not be able to get rid of it. It will keep on going suprachoroidal. I would have just taken that infusion cannula out and put it onto the other cannula, and that would be the only difference. Otherwise, very well managed by Sangeet as usual. So I always appreciate his surgical techniques. So well done.
Thank you, sir. MPS sir, and then Dr. Rajiv.
No, yeah. Sangeet, I have a question for you. When you put the cannula, did you first check that the cannula is inside?
Yes, sir. I checked that it was inside. I actually did not clear it of that fibrin tissue which had been left over there. And you can see, like, once we had removed the oil, there was free flow of fluid, which also means that the
cannula was patent.
Yeah.
And if there was any tissue, so what I am coming to is something else. When you look at the manufacturing of these cannulas, so you have a portion which is tubular and you have a hub portion.
Yes, sir.
Two are actually joined together.
Yes, sir.
So if you are using a used cannula, there can be a rupture at the junction of the tubular portion and the hub portion.
Yes, sir.
There can be a micro leakage in that area. So when you are infusing air which is under pressure, and by chance if you have any any membrane present in front, you can actually have the air going into the suprachoroidal space. It was not because the membrane was presenting, but maybe this cannula was a reused cannula. It was not a new set. So that could be one of the explanations for the suprachoroidal air.
Yes, it could be, but as you see, once we were infusing saline, there was no leakage of saline into the suprachoroidal space. And secondly, after the first episode, the second time when I switched to air, it went in smoothly. We could do it properly.
And the second thing which happens is I've had the exposure, this thing that oil has gone into the suprachoroidal space because the assistant moved the cannula, so it got pulled off a little bit. We were not taping the cannula, and then it went to the suprachoroidal space.
MPS sir, last thoughts.
So before MPS sir, Srinivas, a question for MPS sir also. He can include that in his comments. Sir, is there any possibility of air embolism as a result of the thing? You can take my question also answer together.
No, let me clear before the air embolism will occur only if your infusion air pressure is higher than the perfusion pressure of the eye. That is, if the vertex vein pressure, it should be higher than the vertex vein pressure. So they say that it should be much above 40 or more before it causes air embolism. Otherwise, it will not flow.
So, but there is always a possibility.
So if you keep it at 20
just wanted to
or
point
25,
out yourself
no,
that
if you
there is
keep
always a possibility.
No, if you
Because
keep
we
it at
don't
20
know the
or
actual
25,
pressures existing at that time in both the vortex veins and the, of course, he knows the intraocular pressure, high pressure, but not the vortex vein pressure. So would there be a possibility, even the least possibility?
I agree with Dr. Ajay about the crack between the hub and the body of the cannula. That has happened to me as well. And here, if you see Dr. Sagit's video, when he presses inside, you can see it bending over, and then subsequently when he releases, it goes almost tangential. So there is a possibility that there is some amount of the ciliary body and the peripheral retinal passment and detachment is there, and so when he releases it, probably goes back inside and then allows the air to go back. So I have had these kind of situations, but what I do over time is to remove this and use a 6 millimeter cannula. So I'm never brave enough to use the same cannula and then have more problems. So I usually remove it and replace it with a sutured 6 millimeter. And about the air embolism has been described when you do large choroidectomy, as in when you're doing resection of a tumor, when you do a resection of a melanoma and leave a large area of the choroid being bare. So in that situation, they suggested not to do a fluid air exchange, but then use perfluorocarbon and then do reservoir coagulation. In that situation, when the large area of the choroid is exposed, that can definitely give rise to air embolism, and the patients have had air embolism in such a situation.
Fantastic. Thank you, Sangeet sir, for sharing the interesting.
Thank you. Thanks.
We shall now go on to our next speaker, Dr. Swapnesh Samant, who again a very prolific surgeon from Anidip Eye Hospital and Institute from Mumbai, and he is going to be showing us living on the edge, tricky surgical case. On to you, Dr. Swapnesh.
First of all, good evening to all the seniors and my teacher, and thank you, Chitra ma'am and Srinivas sir, for giving this opportunity. I would be discussing a case of PDR and would be stressing on the facts that though we have modern instrumentation, sometimes going back to the age-old simple instruments to get out of a tricky situation can help. So I hope my video is visible.
Yes, sir.
We are going to discuss a case about bilateral PDR where laser panretinal photocoagulation was done initially to stabilize the diabetic retinopathy process. The beginning of the left eye vitrectomy is seen here with clearing of the vitreous near the ports and the anterior vitrectomy completed. Diabetic vitrectomy also has many challenges in form of vitreoschisis. So induction of PVD is very tough. You can see a flat tabletop configuration of the posterior hyaloid in this particular case, which is making the PVD induction absolutely difficult. With the modern vitrectomy, fluidics, as well as the cutter, the port optimization, modern use of these small gauge microforceps, the dissection can be a bit better. However, I had to resort to use a 24 number needle to create an opening in the posterior hyaloid because I couldn't get any cleavage plane using the forceps. We have to be extremely careful at this step and see to it that we are not traumatizing the retina below. The mouth of the cutter is engaged in the subhyaloid space to proceed with the dissection of these membranes.
Dr. Swapnesh, can you please stop the
Because
video?
of the port optimization,
Yes.
desegmentation.
Just stop the. Can the moderator of this Skype Zoom, can you just mute Dr. RP Singh?
Yes, there's a lot of background noise coming from his end.
I think he has muted already, Dr.
Okay. Continue, Dr. Swapnesh.
Yeah.
Is quite easy, as you can see. There are multiple areas of fibrovascular proliferation with point attachments. Hence, we have to rotate the mouth of the cutter as well as sometimes use our left hand to proceed with the dissection. Now I am using forceps to loosen the posterior hyaloid over the optic nerve head. We have to be extremely careful while doing this procedure because we can induce a lot of bleeding if we pull on a particular vascular area. Proceeding with the technique of lift and cut, we have to be gentle in doing so. Once you are sure that all the attachments are clear, then you can use forceps to proceed with a larger area of lifting up the membrane. With the modern machines, with just a click of one foot switch button, you can increase the intraocular pressure and stop the bleeding temporarily or slow it down. With the help of controlled suction, you can absorb the pre-retinal heme. Once the area of hyaloid is loosened up, it's better to eat it up and then proceed with further lifting up of the membrane. And once the posterior pole is cleared, then you can proceed with clearing the membrane over the peripheral retina. Fill-in endolaser is done and the case is closed with the injection of anti-VEGF. This is a post-op result in the left eye after 1 month.
Thank you very much. So that was the case. The thing was that we tend to be so obsessed with the modern instrumentation using the chandelier, but in these tricky situations, it's important to again know what the teachers have taught us, the basic principles of getting the edge of the posterior hyaloid, and it can be achieved with a humble instrument like a 24 number needle. So that was my bit.
Thank you, Dr. Swapnesh. It was a really an interesting case. I think a humble needle technique I had heard somewhere. Is it Dr. Hemant sir or MPS sir?
MPS.
I heard that both of you presented one of these in the ASRS this thing, if I'm not wrong. So I would like to hear from you both. Please.
Yeah, I did use that. Basically, I create a pick. So I think what you're doing is on a 23 gauge, you can use a 24 gauge needle, or I use a 26 gauge for a 25 gauge vitrectomy. So what I create is I do use this, especially if it's a taut hyaloid and you're not able to get a purchase from the cutter, you make an opening and then use the cutter to do rest of your work. It's a fairly elegant technique. So I could see that you had done it very well. Very nice.
Thank you.
MPS sir, I also saw one of your videos describing this bent needle previously. Am I right, sir?
Yeah, I have a presentation which is called the humble needle.
Humble
so
needle.
I don't use a bent needle. I use a straight needle for multiple things, like for this as well as polishing the lens and things like that. So the whole presentation does using the needle. So as far as Dr. Swapnesh's case is concerned, like he did a great job of it. it just highlights some of the features of a diabetic vitrectomy. So one of the dictums is the more the details you are able to see of the fundus, more difficult the surgery. So here we are able to see all the details indicating there is no hyaloid separation. That means there is no vitreous hemorrhage. That's the reason it's going to be difficult. So only difference in how I would have managed this, once you have made that opening, this would be an ideal case where you can very gently inject the viscoelastic through that. That will very gently separate the hyaloid to a reasonable extent for us to use the cutter. And from there, I would usually take it to the periphery, then work back, because most of your dissection was posterior. So which you usually have your heart in your mouth, because that's where it's going to bleed. That's where you can have breaks. So I would usually start there if the peripheral hyaloid separation is not there. Then from there, take it to the periphery, then work around and work towards the posterior port. And these are the cases where a bimanual may not work in the initial phase, because once a reasonable amount of hyaloid has been separated in the periphery, then a bimanual works. If hyaloid separation is not there, it's going to be difficult.
No, Swapnesh, one comment. Yeah, one comment that you must remember that this 2 rupees needle, I've done a lot of work on needles, and I have presented on a needle picking up of the membranes from the posterior retina. You must remember the needle side edges are cutting edges. Yes, so you can use the tip of the needle for cutting, making an opening, while you can use, as Hemant said, when you use a bent pick, you can use the side cutting edges of the needle for progressing forwards. So it is not the mechanical pull alone of a pick, but it is the side cutting which can do the trick in most of the situations. So you have this long thoracic surgeons use this 26 gauge needle, which is 32 millimeters long, which can be done with a 25 gauge, vitrectomy. So you have to bend it only slightly so that it can go through a 25 gauge port, and it works extremely well. So, all the tricky cases where you do not want to do a bimanual surgery, and as Dr. MPS said that you will do a viscodissection, you can also on a constellation perfuse, and with a left click, you can perfuse fluid below it and cause a dissection plane, and it works extremely well.
Thank you, sir. Thank you so much.
Shall I go on to our next speaker? Yeah, thank you, Dr. Swapnesh. Wonderful. We shall now go on to our next speaker, Dr. Rajiv Jain, who's again a senior vitreoretina consultant from Save Sight Center, Delhi. And he's going to be talking on finding retinal break by injecting subretinal dye. On to you, Dr. Rajiv.
Thank you, ma'am. And thanks, Dr. Srinivas, Dr. Chitra, for making me part of this symposium. So I'll start when Srinivas called me, he said it's a Brahmaastra symposium. I said Brahmaastra is something which you try in the end when everything else fails, right? So this is a way of localizing the breaks when you are not able to visualize it. Although a lot of times you don't need to actually localize the break, the kind of surgery I'm showing you. But still, it's always better that you are sure that you have seen the primary break and you have lasered it. So I'll start the video, and I hope audio is visible.
This video shows localization using BBG dye. This was a case which was operated by us 3 months ago for macula of retinal detachment, 360-degree barrage laser, as you can see. And now he came up with the superior subretinal fluid. We could not localize the break. So diathermy was used to create a retinotomy, and this retinotomy was done so that we can push the dye inside. BBG, brilliant blue-green dye, which we use to stain the ILM, which is non-toxic subretinally, was used to pushed through this retinotomy, as you can see here, and this dye goes and stains the subretinal fluid. Here you can see the macula is still on, and this is this detachment, the subretinal fluid is beyond arcades. So here the whole extent of detachment is delineated. Now PFCL was injected on the posterior pole. The purpose of this PFCL here is to push the dye towards the periphery and to look and to see from where this subretinal fluid escapes, and that will help us delineate the break. Now, as I am pushing PFCl, perfluorocarbon liquid, inside, the subretinal fluid is pushed towards the periphery, and the dye along with subretinal fluid is getting pushed, and as you can see, more and more PFCl is filling up the vitreous cavity, and you can see I'm injecting. The bottle height is low right now, and some more fluid, and I can see the dye is coming out from one of the sides, and there was a break right at the edge of laser scar, which I could not see earlier. So this is a great technique of localizing break in these kind of situation. You can see the dye coming out of the break at the margin of detached and attached retina laser scar, and once this is done, PFCl air exchange was done, and we have localized the break. We have a posterior retinotomy, so once PFCl is removed, further air exchange is done, and through the retinotomy whatever fluid seeped inside was removed, just like fluid air exchange through the retinotomy, posterior retinotomy, which was used for injection of the dye, and laser was done on the retinotomy, and laser was done at the site of the break, which is still not visible, but we could see because of the dye, and 2 rows were given all along the. Hi.
Thanks for your kind attention. I think I've used it in a lot more cases now. And the trick is.
Could you stop sharing?
So we used it in other detachments also, and if the macula is off, so that the submacular RPs or the retinal elements are protected, we use PFCl so that the dye doesn't seep submacular, and it works well. So any thoughts on whether this dye can lead to long-run toxicity of the retinal elements, whether it should be further used or not? And that is what was always bothering me. Though literature says that this dye is normally not toxic to the retina. Thank you.
Dr. Rajiv, did you dilute the dye before you use for this localization of the breaks?
So it's a BBG dye. So dye which we took, it used 1 to 2. So BBG which we normally use for ILMP, but we diluted it to half. That is why it was a bit light.
Okay, fantastic. Thanks for sharing that interesting case. Dr. Undi, I just had a quick question. We knew that it was a very sectoral kind of retinal detachment, and we know that in these kind, usually it will be at the edge of these laser scars. So would it have been possible that just first try with the PFCl injection and look for the egress of the fluid, or whether putting the dye in these cases is really mandated? Second thing is, in case if the macula is detached and you don't see, and I've seen many of the authors still using that technique to identify the break where in the periphery, not in this case, but even in the total retinal detachment cases also. So in which cases would you advise to go ahead with the usage of the subretinal dye technique?
So Rajiv has shown a very elegant video. It was really well made, and it's like a Bollywood manufactured beautiful video. It shows perfectly the dye coming out of the right place. So when you have such conclusive evidence, it looks really a really good technique to use. See, we've been all of us have been using PFCl, or when you do FG, you're looking for the egress of the dye for ages. But this adds an amount of surety. See, a couple of things that have been taught to us is that when you have one break, always look for another break. Possibly you could identify more than the expected breaks with this particular technique. So I think, yeah, if this was in the scenario and the break is not obvious, it would really lead to some amount of surety during the process. And just for your information, I don't know, I think MPS sir can comment about it. BBG dye is supposed to be a vital dye, which is neurostimulatory. So it might be actually good for the RP, not bad. It is the same blue color that you find in blue M&Ms. So it's supposed to be have a neurostimulatory effect. So I'm not sure about the RP toxicity effect of the BBG.
Yes, MPS sir.
Very elegant video, Dr. Rajiv. One thing is the previous technique which you described was using a 42 gauge cannula. So that only problem in making such a large retinotomy after doing a diathermy is like the dye can express through that itself. And you did the posterior retinotomy and the PFC covered it. Otherwise, there's a possibility of the dye escaping through your retinotomy itself. So the original technique described was using a 42 gauge cannula so that like the dye doesn't escape through the injection site. My modification is I use a transcleral injection of the dye. So I don't use a transretinal injection. A transclerally with a 26 gauge needle go inside and inject transclerally and then put a perfluorocarbon bubble and see it. They're particularly useful in high myopic patients. And there are high myopic patients and you're not able to identify where the break is. In those situations, it's very, very useful to identify. I had a patient whom I have operated 3 times, 4 times and kept coming back with a pocket of fluid. And this dye technique showed us exactly where the break was. Whether it is toxic, the literature does say that it can be toxic, but the issue is like you're draining it along with the subretinal fluid when you do. So only thing is when it goes to the macular region and it can accumulate there, then it can give rise to possibly a toxicity, but I have not had any issue of a toxicity happening with this dye. But when you do an FGE, and particularly when you put perfluorocarbon posteriorly and when you do an FGE, then you pretty much almost all the dye you remove it when you do that. So it's unlikely to cause a toxic reaction.
Yes.
I think
Dr. Rajiv, sorry. Dr. Rajiv, one quick question. You said you use it only when the macula is attached and not in the detached cases. Did I hear it right or?
No. When the macula is detached, I use PFCL before injecting the dye.
So Rajiv, just one last
to
question.
prevent the dye coming to macula, I think that is what he was mentioning. That we try to
So
avoid.
up till the posterior pole, you are injecting that so that you don't want the dye to come in.
Yes.
So Rajiv, did you use did you inject the dye manually or use the automated through the silicone?
Sir, I use it manually. So
yeah,
I work
Dr.
with
Ajay,
So I agree whatever Dr. MPS said, but the only thing is I want to ask MPS with a shallow detachment like this, bullous detachment has been described to inject it transclerally, where you can inject transclerally, you are sure that you're not going to damage the retina. But maybe in the MPS's hand, it's very safe in all situations. But I agree with the 41 gauge needle. I have done it once and it works very well. And then you can use 0.1% trypan blue. That's what the literature describes. And they have actually, like all the retina and things, every small names are given, abbreviations. They call it a DTech, like a dye ejection technology. So it's very interesting that we have names for everything.
I agree. The shallow detachments, it's better to inject transretinally rather than a transcleral technique. I agree with you.
Thank you so much. Thank you, Dr. Rajiv. Very nice discussion you brought up. Thank you very much.
Thank you very much. We shall now go on to our next speaker, Dr. RP Singh, who's the chairman of Visitech Eye Center at New Delhi. And he's going to be talking another interesting surgical case, removal of a large non-magnetic intraocular foreign body. On to you, doctor.
Sir, you are muted and you can tell from which place you are and then you can start the
Thank you, Dr. Chitra and Srinivas for giving this opportunity. Actually, I'm in Mongolia right now and time is 10:30. I was out for dinner. Otherwise, the restaurants will close. So I'm sitting in a restaurant actually.
Thank you,
sir. Yeah, and sorry for the background noises. I've just asked them to mute their music. I'll be presenting a case. This boy was sent to me with the history of trauma. I'll just in. Yeah, so this boy was sent to me with the history of trauma, which was the corneal. The repair has been done in the Jammu, and when this boy was come, he had a traumatic cataract and the total vitreous hemorrhage.
We don't see your video.
Just it. Can you see the screen now?
Yeah, yeah.
Okay.
Sir, please
So
go
this,
ahead.
yeah. So this he had when we examined, there was this repaired corneal spill puffing at the junction. You can see at the limbus, dialysis, and hyphema. So we decided to take this patient for surgery. The first, the cataract was removed was done. We injected the dye, and you can see there was the iris which was there. So that was cut. There was a total dense vitreous hemorrhage, so there was no glow behind. So generally, it is very difficult to operate cataract in such situation because you don't see any posterior capsule. So once because it was a soft cataract for the 18-year-old boy, it was soft cataract. So the lens aspiration was done, and taking care that not the posterior capsule is damaged during the surgery. You can see there is no glow. There is absolutely red glow because of the total vitreous hemorrhage. We injected a single piece lens into the bag. After that, the careful 25 gauge detachment was undertaken. The 3 ports were made and started. Initially, it was a kind of a blind. You can see there's an absolutely dense vitreous hemorrhage, like a ciliary bleed. After once we started clearing the vitreous hemorrhage, the retina was not visible. Then we noticed a small shadow here. So that gave me idea that there's some fawn bodies lying there. And once we cleared the entire vitreous hemorrhage, you can see that a large cylindrical kind of a fawn body was there. So we tried with the magnet. So we inserted the endomagnet. This is a 20 gauge endomagnet. And we tried to lift it. That is normally what we do. We lift with the magnet. You can see there's a fawn body lying there on the retina, which is superior to the superior part of retina. But to our surprise, it was a non-magnetic, so we couldn't lift it up. It was not possible to lift with the magnet. It was absolutely non-magnetic, large cylindrical fawn body. Then we tried with the fawn body phosphate, but it was too large to lift it up. You can see the fawn body couldn't grab it. So at that moment, we were in a large dilemma that how we are going to remove this fawn body, just lying there on the retina, but there is no tool to remove it actually. So what I did was I just enlarged the prong of my fawn body faucet. In fact, I lost this fawn body faucet after that. I couldn't reuse it. I enlarged it, checked it whether it is moving. Then we enlarged the sclerotomy circumferentially. Now the challenge was there to how to insert this fawn body faucet because now it has become big. So we first inserted one prong, rotated the fawn body forceps, and then the other prongs. So there are 3 prongs body forceps. And to our luck, it could just grab it. It was just big enough to, we just aligned it in the direction that, so we were lucky that we just grabbed it. We pulled it. It didn't force it out because you can lose the fawn body. We just enlarged the fawn or sclerotomy further. And then you can see that a large fawn body was removed from there. Then when we went back retrospectively to check, then we came to know that it was a history of a firearm injury actually, that he hid it from us. He didn't tell us that he had the fire injury. And that is how he got, so it was a alloyed basically, it was a bullet, a part of the bullet actually.
Thank you, RP sir, for showing that and a slight modification of what you did with that. I think we use now the basket forceps also. Dr. Manish had done that, and I think that opens up the prongs relatively well. That could be of good use. That one I could say about it. And second thing, would it have been better if you had implanted the IOL later after the foreign body removal? Because sometimes if of course this was small foreign body, but if it's a bigger size, and rather than extending the choroidal wound, you could have just made a scleral tunnel and then make a small rupture in the PC and bring it out through the AC, so that even though if there was any bigger foreign body also could have come, and later on you could have always implanted the IOL. Just another way of
Actually,
just asking.
you're right, actually, but going by the history, we didn't expect the foreign body to be there because he had just a history of fall. The X-ray and the ultrasound didn't pick it up actually because it was so dense vitreous hemorrhage, and so it missed actually. So we were not actually anticipating the foreign body into that. So we were not prepared actually at the time of surgery.
Srinivas, can I make
Guha sir and then Ajay sir, please. Yeah.
Thank you. Srinivas, in my 13 years of experience in working in Srinagar in a ward situation, in fact, I have such videos also in my presentation. These are typically pellets used in firing by the J&K police on the stone throwers. Previously we had, I'll show you in the video, we used to take it out with a small Calisian scoop. We had no other instruments. But thanks to Manish Bapaye, which has 4 prongs, which opens up to 7 to 8 millimeters. Life is very easy now to remove such pellets, as has been very well shown by RP. That's all.
Thank you.
Ajay sir, you are muted.
Srinivas, I would also like to comment.
Yeah, go ahead.
What what Dr. Goa is saying is correct. You know, when this pellet injury thing started, so Dr. Tariq from Srinagar, he actually called me up. He said, what is to be? Manish was developing his forceps at that time, which is a opening diameter of 6.5 millimeter. So at that time, these forceps were not available. So what I did a little different was, so we got a tubing with a wide bore internal lumen, which you can actually insert through a sclerotomy, which collapses. You apply suction and pick up the foreign body at the tip of the tubing, and we removed it with the tubing. So this few pellets like this had been removed again in Srinagar, but I think Manish's forceps works pretty well.
Because of the one danger, suddenly the suction breaks and the pellet falls.
No, that you could have first tried with the cutter also. If it doesn't try with the cutter, then
with a soft tip, you can use with the cutter. I don't think you can cut the foreign body.
No, not cutting, sir. Just for aspiration, like how you.
But how do you take it out?
No,
you have to
it is too big.
No.
It is too heavy to pick it with the cutter.
It is heavy. It's a pellet. It will
Yeah,
not come with the
Yes.
So
it's got a dumbbell-like thing. So it has.
Just asking, if it doesn't come with a cutter while aspirating, does it come with a soft tip?
No,
really challenging.
No suction within that tubing. It comes like this. You hold it and bring it out. It won't come with a cutter.
Go with the
dangerous to use suction.
This is too heavy to
Neeraj sir, go ahead.
Unless and until Srinivas, you're using diamond dusted cutters.
Even I have 2 patients with this foreign body removal who didn't divulge actually what kind of injury they had. And frankly speaking, as RP said, it was too difficult to get out. What I had to do, I had to make a corneal section and went with the tooth forceps inside through the corneal section and took them out. That was the thing I did with 2 patients. I didn't have to make a bigger sclerotomy or looking for a forceps. I had to go through the corneal section and I could take them out safely. And one patient is 6'9", other is 3/60, and both patients, they are doing well.
Actually,
I have an experience with the section is a bit tricky because the wound is open, is bigger, so it's going to collapse. There's the risk of creating the detachment and the break in identity break. That's it.
I didn't have any other option. Even the foreign body forces are not too molded. I'm just telling you how I handled it. It was a difficult.
Actually, at that time, it just struck me because I didn't have that money forceps. So it just like what to do. So
we really appreciate it, sir.
Innovated that way.
Our presence of mind at that time is what is very important.
That is what which is important at
because
the time of.
I had Manish Bapa's forceps and it was not opening only the prongs. So I was stuck. So even though you have that, sometimes it might not. So you definitely need to think otherwise. I really appreciate
you need to improvise upon your whatever you have.
Mahesh, you have something to add?
Last comments from NPS.
Yeah, regarding Dr. Manish's forceps, like I had the opportunity to use it and test it initially in Kashmir. So he was kind enough to make me as a co-author of it. Only thing we need to understand as far as Dr. Manish's forceps is concerned, any forceps when you open, it doesn't move forward. So Dr. Manish's forceps moves forward a little bit. So you need to be a little bit careful when you use it close to the retina. So it can move forward and touch the retina. So that's something which we need to be aware of when you're working close to the retina.
Exactly. And the irregularity of the prongs also sometimes I feel it difficult, sir. We're looking at the contour. Sometimes one prong might touch the retina. I always fear that. So that also, but I think with the usage and the experience, you might get through it. I think. Yes, last comment, sir. Hemant.
Yeah, see, I use an ENT forceps. There is a foreign body forceps which has the width of at its maximum width is about 3 to 4 millimeters, and it has an opening of up to 6 to 7 millimeters. It opens up like an alligator. It's like an alligator forceps, and it has got serrations, so you can grab large foreign bodies. I've used that to take out stones, especially after blast injuries with stones inside the eye, and glass foreign bodies are all which can be grasped very easily with that.
Do you use it through the sclerotomy, Dr. Hemant? Or
with the sclerotomy? Yeah, with the sclerotomy.
In fact, Rumex used to make it. We had one, if Neeraj would remember, we had a forceps which was just like an alligator, and it also had a surface which had a hole here. So we could actually pick it up and work pretty well. But that didn't have an opening of 6 millimeter. It was probably a 4.5 to 5.
Thank you, sir. I think we can go with a set of debates, madam.
We'll start with the debate.
After completion of 2 candidates, then we'll have a set for
discussion. Yes. So
Thank
we have Dr.
Thank you, RP, sir.
Yeah, thank you very much. We have Dr. Manjunath and Dr. Neeraj debating against each other. Dr. Manjunath is a consultant at Ganesh Netralaya CC Karnataka, and Dr. Neeraj is a senior vitreal retina consultant at Fortis Memorial Research Institute, Gurgaon. Now, Dr. Manjunath is going to be talking on stage 3, zone 2 ROP, laser is a must. And against him is going to be, I believe in anti-VEGFs by Dr. Neeraj. So let's hear each of them in their 4 minutes and then go on to the discussions. On to you, Dr. Manjunath.
Yeah, at the outset, I would like to thank Chitra Madam and Dr. Srinivas for the opportunity. The topic given to me is zone 2, stage 3 plus or minus laser is a must. So there is a disclaimer, the content expressed are my own and it's not endorsed and purely for information purpose. So why we have to know about this ROP is mainly because of it's one of the bleeding causes of blindness, and there is of late there has been increased incidence of medical legal issues. Everyone is aware of these huge compensation which doctors have to pay. Recently, there was an article in Times where the doctor has to pay 70 lakhs of compensation just to having a missing the screening. Just imagine what would be the case if you have mismanaged the case or improper treatment. So these are the zones which have been described, and these are the treatment options which are presently available with us. So these are the pictorial representation of the various indications for laser. So just recap of what is stage 3. It's a ridge with extra fibrovascular proliferation. So with due respect to my opponent, so this is a gold, and there's a statement called all that glitters is not gold. So for me, the laser is a gold standard. Anti-VEGF is something like it glitters, but definitely not a gold. So the main thing is what is the aim of treatment? You ablate the entire avascular retina rapidly and completely as far as possible. These are the various indications where the laser is indicated, has been defined by ICROP staging. So when and whom to laser? So eyes with zone 2 stage 3 plus is a definitely indication for a laser, and zone 2 stage 3 with pre plus and pre threshold nowadays is being considered for a laser. Looking at the babies which we get very sick, and when there is a poor compliance for follow, and whenever there is a zone 2 stage 3 with PMA more than 45 weeks, and also whenever there is associated comorbidities like history of any blood transfusion or a poor weight gain, these are the indications where we need to do a laser. So when we do a laser, mainly within the 2 to 3 days of a diagnosis of disease, because we know that once vitreous is involved, the laser treatment doesn't work effectively. So these are few technical aspects. It is generally done under topical anesthesia. Both diode and green lasers are found to be equally effective. Confluent lasers are definitely more useful than non-confluent laser. single sitting and multiple sitting lasers have found to be equally effective. So of late, what we are using is a posterior targeted laser. So we generally laser the posterior to wrist. So we have found that it eliminates the additional area of ischemic retina, so that the chances of recurrence are very less. So these are the pictorial representation of a non-confluent as well as a confluent laser in case of ROP. So when you decide about mainly the retreatment is generally wait for 1 or 2 weeks. Do you look for the regression? If there is no regression, you may always have a chance to laser the skipped areas. There are a few pictures showing the laser which are done to the skip the areas after the initial treatment. So we have definite guidelines for a follow-up following laser. We do follow up for 3 to 5 days of the laser and look for a regression of ROP. Then after 6 weeks, you can follow it once in 3 months for the first year of following a treatment. So there are few complications which have been defined. Most of them are theoretical, like over treatment, under treatment, the corneal burns and cataracts. And myopia is one thing which has been described of it. But so coming to anti-VEGF, like there is a lot of confusion among the anti-VEGF, whether we have to, what molecule you have to use, whether innovate or you go with a biosimilar. Even with the dosing, whether you have to have half dose, full dose, there is so much of confusion which are there in anti-VEGFs. So something like anti-VEGF is like a blanket therapy, as there is a statement called one size doesn't fit for all. And there is, you have to really concerns about the safety of a procedure and worries about systemic absorption, neuro and delays. So this one study I would like to quote, like an eye-opener study which is in Cochrane review in 2016, which clearly states that the use of anti-VEGF doesn't reduce the risk of retinal detachment and recurrence of ROP. So there is insufficient data which precludes the strong conclusion of favoring the routine use either in monotherapy or in conjunction with laser. So when to use anti-VEGF? Whenever I do, like there is a very hazy media, or when there is the zone 1 ROP or AP ROPs, or as a combination, or sometimes in monotherapy. But like whenever there is a ophthalmics and not readily available for a laser, I do consider for anti-VEGFs. So these are the few studies which my opponent would be quoting, like BEAT ROP, rainbow extension studies, which have showed that there might be a usage of anti-VEGF which are more useful than rather than laser. So just to conclude, laser definitely is time tested and more than 90% plus cure rate. It's a well-established technique and there is a concrete guidelines are present. It's safe and secure. One thing is that there is the risk of peripheral avascular retina, which is averted forever whenever you do a laser. So one thing is, once the ROP is regressed with laser, it never recurs. There we have decades of follow-up and it's very economical when compared to anti-VEGF, where there is always there is a risk of a late recurrence. There are high chances of retinal detachment, breaks and all. So final thoughts, laser continues to be a gold standard in ROP management. Recurrence of regressed ROP is almost nil. In zone 2 ROP, benefits of laser outweighs the injection. Evidence prove that the grade of there is a myopia or visual field loss after the laser which are done in zone 2 stage 3 are limited. So anti-VEGF is just like a shortcut and can never be a substitute for a laser. I would like to just finish my talk with so my opponent just raise your words and not the voice. It's the rain that grows the flowers, not the thunder. Thank you.
Thank you. Thank you so much, Dr. Manjunath. It was really interesting, and your final quotes were also very interesting. Over to Dr. Neeraj, sir.
Okay, thank you.
So the time limit is 4 minutes and your time starts now.
Okay, thank you.
Sunil, I would really want you to please check on the time. You've not mentioned once during the course of this webinar. We are running quite late.
Thank you, Dr. Chitra ma'am and Dr. Srinivas for giving this opportunity. I'll be introducing myself to stage 3 zone 2 ROP, and I believe in anti-VEGFs. Laser has been a gold standard for ROP treatment, as Dr. Manjunath said, but I think there is a shift, dynamic shift in favor of anti-VEGF for posterior ROP, as we are seeing role of anti-VEGF in diabetic retinopathy away from lasers. And more than 200 papers have been published in the last 10 years on role of anti-VEGF in ROP. And we all know laser is a destructive procedure and there is no tissue conservation. With anti-VEGF therapy, we are looking for tissue conservation, and especially if it is zone 2 or zone 1 disease, which gives you field of vision that has to be treated. And there have been evidence of anti-VEGF efficacy by BEAT ROP study, Rainbow study, Wu et al. It showed that in most of the eyes where you give anti-VEGF drug in stage 3 zone 2 disease, the regression occurs in up to 89% of the patients. And Rainbow trial was a trial to see the efficacy of the ranibizumab, which had a shorter half-life comparison to the bevacizumab, and 0.2 milligram, 0.1 milligram, and laser was compared. And it showed, if you see clearly, the treatment success rate was maximum in 0.2 milligram group, and 75% in ranibizumab, and 66% in laser therapy group. And among the two groups, the children who were given this 0.2 milligram, it had better visual outcome. And if you see, look at the additional treatment, 30% of the eyes in all the groups, they required retreatment. So the treatment rate was, rate was almost similar. So this study highlighted that this ranibizumab is superior to laser therapy for both zone 1 and zone 2 disease. And it had got better visual outcome, less chances of myopia also, and safety profile is maintained because the half-life of ranibizumab is so less and systemic VEGF level were not suppressed as seen on plasma levels. And laser is effective, but there are documented adverse effects like cataract formation, vitreous hemorrhage, syncytial formation, and absolutely visual field constriction, which will be there if you go into the zone 1 and zone 2, and also high chances of myopia. And also laser requires more longer treatment. The child has to be sedated or intubated. And also there could be adverse outcome when you use laser in zone 1 disease. And advantage of anti-VEGF is ease of use. Just 5 minutes you can do the procedure, and modest preparation, less staff time and less effort on surgeon part. And there is a rapid response to the treatment. Within 24 hours, you see the regression of the disease starts happening. And you have better visual field because you are not damaging the retina. And better visual acuity in anti-VEGF group shown in BEAT ROP and even this Rainbow study. And but we have some concern, like there is delayed vascularization, recurrence is more, and the challenging follow-ups are there, which you can do in a tailored approach. Just you can look at this picture. You give laser treatment, the vessels, they don't progress after this avascular zone. And if you give anti-VEGF, the vessels, they start reversing. So you are basically vascular in the retina. This was a patient, 29 weeks gestation, 950 gram, and showing zone 2 posterior stage 3 ROP. After giving injection, you can see the good regression of the disease. Another patient, you can see a fibroscope proliferation, the extraretinal fibroscope proliferation here. And after giving that injection, you can see the rate has entirely progressed, means the vascularization has started. Another patient of zone 1 disease, you can see the angry looking blood vessels. You can't do laser in such cases. By giving anti-VEGF injection, you let the vascularization progress and maybe plan for laser later on. So in this picture also, you can see the vascularization has stopped, the bleeding has occurred, and the ridge has started progressing after anti-VEGF therapy. And the remaining treatment you can supplement with laser photocoagulation if the blood vessels, they are not able to reach at the periphery. So to conclude, anti-VEGF therapy is a rational approach in cases where laser treatment will be damaging the retina, especially in zone 1 and zone 2 disease, especially posterior zone 2. And you are not obviating, making the child losing his field of vision, which may be required when he becomes adults. And it also, vascularization goes toward the periphery, and it may give you a full field of vision. And laser treatment, we can consider definitely if the vascularization is not complete. So I will reserve my comment to do anti-VEGF therapy in zone 1 and posterior zone 2 disease, and if anterior zone 2 also we can do. Thank you very much.
Thank you very much, Dr. Neeraj. So, Srinivas, we take on the debate.
Can stop this. Yeah, thank you. Thank you, Neeraj sir. Ajay sir and MPH sir. See, the question here was zone 2, stage 3, pre-plus disease or no plus disease. So that was the debate. I know in case of any of the zone 1, anti-VEGFs have become the rule. And in case of plus disease, yes, we do give anti-VEGFs. But zone 2, stage 3, with pre-plus or no plus disease. So what would be your preferred choice of treatment? Ajay sir and then MPS.
So, what I do in these cases is that generally it depends upon whether there's a plus component present or not. But if it is zone 2 posterior, Earlier, I used to laser all these patients, but lately, for the zone 1 and zone 2 posterior, we have been giving ranibizumab injections with separate vials for right eye and separate vials for the left eye, not trying to use the same vial for the risk of infection. Then we follow up these patients, and if required, I have not till now given a second injection of ranibizumab. Usually the angiogenesis has extended up to zone 3. And at that stage, if required, after about six weeks or so, we have done additional laser. And that is what I follow up at this point of time.
Yes, MPS, sir?
Yeah, pretty much the same. More posterior the disease, we'll probably use anti-VEGF so that like spare as much posterior retina as possible. More anterior the disease, we tend to do laser photocoagulation. The one problem with anti-VEGF is it kind of masks the disease for about a month's time. Then by the time the children become a little bit older, it becomes difficult to screen for the anterior periphery if it is ischemic or not. So wherever doubtful, then yes, we would do laser photocoagulation. More anterior the disease, yes, laser photocoagulation. One thing which I would differ with what Dr. Neeraj said, that neovascular vascular is normal vascularization does not progress to the area of laser photocoagulation. It does progress, actually. You can see the vessels growing into the area of laser photocoagulation once the disease regresses.
The other thing important, Srinivas, is that patients with an anti-VEGF, if you repeat the second dose and you do not do laser, they need to be followed up for a much longer period of time. Well, that becomes a little problematic at times. So that is an issue. But laser, then it's sort of what Dr. Manjunath said is the end point. But one thing which I'll ask all the panelists, do you have any, I didn't find anything in literature that if you're doing laser in zone 2 anterior, what will be the field restriction in these cases when the child grows up? We can say that peripheral vision is lost, but how much peripheral? I didn't find any report in literature which can quantify the amount of field loss with the amount of laser in which zone it is done. Anything, Dr. MPS?
Not that I'm aware of. I don't know if visual field tests have been done on these patients serially or anything that I'm aware of.
Yeah. So we go on to our next debates by Dr. Manvi Sindel and Dr. Avnesh Upadhyay. Dr. Manvi Sindel is a medical consultant, Vitreoretina Services from Arvind Eye Hospital, Pondicherry, and Dr. Avnesh is a Vitreoretina consultant from IQ Vision Private Limited, Gurgaon. So the topic is non-exudative CNVM preemptive treatment, and the second one is observation. On to you, Dr. Avnesh.
Thank you, ma'am. Thank you, Dr. Joshi sir, for having me here. And I'll be going first as we discussed before. So my topic is whether to actually observe or treat a patient who has a non-exudative CNVM. So I cannot, sorry. Yeah. Sorry. So if you have a patient of before going into the details of the treatment part, let's talk about what actually is an MNV or a macular neovascularization. So when we say there is an MNV is when there is a presence of a macular exudate or a hemorrhage on a fundus evaluation, there is a leakage on an FA, or you see hotspots or plaques on an ICG, or you see presence of intraretinal, subretinal, or sub-RPE fluid on structural OCT. So MNV can be present in cases where you, in the absence of any detectable macular fluid on an OCT, or sometimes this is also not picked up on an FA. But if you do an ICG, those things you can actually see a plaque, or maybe as of now, since the advent of OCTA, we are kind of picking up these sort of vascular networks. So these plaques were actually, even those were published, or they have been described way back in '98, where they have had patients who actually had exudation, and these plaques were actually the ones. So we have been seeing this for quite some time. Problem with the So before going into the treatment part, let's talk about some terminologies where we need to actually understand what does a non-exudative sort of a CNVM means. So first one terminology should be a non-exudative, non-neovascular EMD, where we actually don't see any evidence of macular fluid, or there is no leakage on an FA. And even if we do an OCTA or an ICG, there is no plaque or no vascular network. The other terminology is exudative neovascular AMD, where we actually have both. You see submacular fluid. We tend to see a leakage on an FA, and there could be evidence of a plaque on an OCT, on an ICG, or presence of a vascular network on an OCTA. So this is what we are going to talk about as non-exudative neovascular AMD. So non-exudative means there is no fluid, no macular fluid, and there is no presence of leakage on an FA. And neovascular means when you do an OCTA, there is presence of an MV, macular neovascularization on an octa, or maybe it may have a presence of a plaque or an hotspot on an ICG. So this can be seen in two sort of patients. One is a treatment naive patient where this sort of a membrane is, when you do an OCT, there is nothing there, but we see a membrane on an OCTA. And it could be in some patients where we actually see a CNVM and we have given injections, and that kind of membrane, the fluid has dried off, and we can just see some amount of membrane sitting there, or there will be no membrane at all. So this is another term which is like a treatment naive non-exudative neovascular, where the patient has never been received any sort of treatment. So actually some people may not have an octa or an ICG. So how do you actually pick up these sort of CNVM? Even that is to be discussed. And we can actually, there has been a very good study, and they have said that if we are able to find a double layer sign on a structural OCT, we'll be possibly able to say that these patients are non-exudative CNVM. The sensitivity they have described is at around 80 to 88% of the times. So these sort of things should be followed up very regularly. So now once we have understood what does non-exudative CNVM mean, let's see whether we need to treat or whether we need to observe. So talking about it, this is a very good article which has been published in Ophthalmology Retina, where they had screened around 258 articles between 2014 to 2019, and of that 12 articles were included. So they have actually picked up how much amount of these patients actually had subclinical non-exudative AMD in the fellow eyes of patients who actually had exudative AMD in the other eye. So they came out with the percentage was around 6.25 to 27%. So 1/4 of the patients may have subclinical non-exudative neovascular AMD in the other eye. These sort of patients, they actually don't have any significant decrease in visual acuity, and the vision is more or less the same. They've also picked up that if these patients are associated with geographic atrophy, these subclinical non-exudative AMDs tend to have some protective effect, and they prevent further atrophy of these sort of patients if it is associated. They have further said that how much of these sort of patients, when we have picked up a subclinical non-exudative neovascular AMD, would actually exudate. So that is, they have said that in their studies, in these multiple articles which they have published, they have said the percentage varies from 20 to 80% over a period of 2 years. So they concluded by saying that these patients, which they actually have a non-exudative CNVM, it's an asymptomatic condition. It is definitely a precursor to form an exudative neovascular AMD, and a very good follow-up is required. And they have specifically said that these lesions should not be treated unless it becomes a symptomatic exudation actually develops. And they have asked, before mentioned, these actually have a protective effect in slowing the progression of a geographic atrophy because they kind of supply oxygen to the hypoxic outer retina. These have been further 2 articles which have been published, and they have actually looked into the natural history of these lesions over a period of 2 years. And even in these conditions, they have said that no treatment is required. And the amount of exudation is, again, what we discussed is around, for the first year, it is around 6 to 10%, but by the second year, it may be around 20% of these sort of patients may exudate. Definitely no treatment should be done. And these lesions kind of attempt to reform the choriocapillaries and provide beneficial nutritional support to the overlying RPEs and photoreceptors. So why do we need to observe in these patients? Because the best corrected visual acuity doesn't seem to change. So actually how to actually tell the patient that you may actually go into an exudation later and may require treatment is one thing. And to what point the endpoint should be of your treatment should be, we actually do not know. And as said that 1/4 of these patients may exudate over a period of 2 months or 2 years. So better following up is more required. And definitely they have some protective effect even in case of geographic atrophy. What needs to be actually done is to actually pick up on biomarkers, which has not been very nicely published, and maybe the future studies have needs to be done. And in this, there have been some studies where they talk about the size of the vascular network, but some studies are not actually into agreeing with this. And there is a latest study where they are saying that tiny branching vessels of CNV can be seen in patients which were actually previously treated with anti-VEGFs. So these are not the subclinical ones. So even those are the ones which actually need to be followed up. And then actually there is a tiny branching, they may require treatment. So from my side, unless there is an exudation, we can observe these patients and from there to look into it. Thank you.
Thank you very much. Mr. Sunil, are you there? Mr. Sunil, are you there? I don't know, he's not there.
Okay. I think we can go ahead, Manvi, madam.
Yeah, Manvi.
Thank you, Dr. Abdish. Go ahead with Dr. Manvi.
Yeah, I'm there, ma'am.
Yeah, but then you have to look at the time, no? No, not you, Dr. Sunil. I meant
sorry.
I'm sorry. I'm talking admin Sunil. I'll call him. Yeah. You can talk, Dr. Manvi.
You're muted, sir.
Dr. Manavi, you're muted.
Yeah, I'm sorry.
Yeah.
So good evening, everyone, and thank you, AIOS, ARC, Dr. Chitra and Dr. Srinivas for having me here today. And I shall now be talking on the other half of the aspect of non-exudative CNVM, that is preemptive treatment. So
please stick to time, Dr. Manvi. I've got Sunil.
Yeah. So our actions are limited by the tools that are available to us. So how does this happen? So how have we classically defined the onset of a CNVM? Is with the onset of exudation, whether it is on fundus examination, leakage on FFA, or on the presence of fluid in an OCT. And how have we monitored treatment? Again, in photodynamic therapy by leakage on fluorescein. In the first anti-VEGF trials, that's Anchor and Marina, also by leakage on fluorescein, and it was later only that the OCT biomarkers that we use today came into being. Just like when we play games and you have upgrades, we have had upgrades in technology, which are now helping us see better. So non-exudative CNVMs, like Dr. Avinash just pointed out, have been seen for a long time. They were described histologically in the 1970s, seen on ICGA as the focal hotspots or plaques, as ICG could image below the RPE, but ICGA could not show the exudation. And now, of course, on step source Octa, where we can see these membranes very well, and we can identify them in good manner. And these lesions have been shown in studies to correlate to the ones seen on ICG. And of course, we know various kinds of morphologies of these membranes have been well described in literature on Octa. And as well as Octa shows us how these membranes regress after treatment. Now, coming to some other studies which have been done on these non-exudative lesions, which obviously, as Dr. Avinash pointed out, are currently observed as the standard of care. We have identified some characteristics of lesions which are at a risk for exudation. So one study, this paper from Retina shares that the elevations which are flat like this show a less progression to exudation, but where you have tall PEDs and the height of PED was shown to correlate to a larger chance of conversion to exudation. Similarly, CNVM growth has been documented on Octa even before exudation. So even before a membrane exudates, it keeps on growing subtly, and this can now be documented very well on an Octa. And there are studies which have looked at these quiescent non-AMD membranes or these non-exudative membranes, and they have shown that in the groups which activated faster, the short-term one, the growth rate of these membranes was very high, and as well as their perfusion density, which they did by using some algorithms. There were more vessels in these and they were more perfused. So we have evidence which is showing us that these membranes are increasing in size and various characteristics which can predict exudation. Another this interesting study which looked at the microperimetry of the macula, and it has shown that in areas of non-exudative CNVM, there is reduced retinal sensitivity. And this was very specifically noted over areas of choroidal hyperpermeability with an underlying CNV, and not on those areas which did not have an underlying CNV. I think these studies are very important to show that these are already affecting our vision. Now, coming to therapy, the initial target molecule was VEGF, which is very good at causing leakage. It's 50,000 times more potent than histamine in causing leakage. And the initial anti-VEGF agents, that's mainly ranibizumab, was seen to be very good at stopping this leakage of fluid. But now with newer agents in the market, we can see that we are not only seeing a reduction of fluid with the treatment, but we are actually seeing quite good reductions in the lesion and the size of the membranes also. This is one case of ours, which is post a single injection of brolucizumab, and you can see there's a significant reduction in the size of the lesion itself. Another concept which is there currently in our treatment armamentarium is that of treat and extend, where we re-inject patients until the macula is dry, we extend reviews, and we keep treating them at regular intervals to maintain a dry macula. So a CNVM, you have a network appearing, it grows till there is exudation, you treat till fluid disappears, and then you treat either PRN or TNE, in which PRN is suboptimal because every time the membrane grows and causes fluid again, it causes damage to the retina. So what is our new evidence? We have new evidence which showing us that non-exudative CNVMs grow in the absence of fluid. This can be quantified. Newer agents are causing a regression of the lesions itself. And whenever, even in the case of exudation, treatment is initiated early before photoreceptors are damaged, vision can be preserved. And where the exudation is profound, vision is already damaged. So the future would be good imaging, molecules which cause good regression of the membranes, and the future would be to treat these membranes before exudation to preserve photoreceptors and preserve vision. Thank you.
Thank you. That was a very crisp talk and wonderful. And in fact, both the debates are very good. On to you, Srinivas. But
yeah, fantastic, Manvi Madam, you defended so well and very nice.
Very strong.
Yes, Uni sir.
So thank you for that. Both sides were well presented and diverged only on the last two slides. Basically, it was similar to them. So what I'd like to say is that let's be very clear about what we are talking about. We are talking about treatment naive patients, not a partially treated patients. If you want to introduce the term non-exudative CNVM, we are talking about treatment naive patients. And that too, we have to divide into two components basically. One is a subclinical, which subclinical by nature of its term may turn into a clinically relevant membrane later. And the second is quiescent. A quiescent does not essentially means a membrane that is not likely to convert into. And how do you differentiate? Time will tell you. The only time can tell you about the differentiation till we have better evidence. And OCTA and the presence of small fibrillary branches and acute angle, high vessel density could be an indicator. Now, when we talk about subclinical membranes, I'd like to say that these two percentages are in my mind. It takes about 15 months for on average, a mean average of 15 months for activity to present in some clinical membranes, and it happens on a whole in non-exudative in 22%. So it's a rough idea that 22% contains your subclinical membrane component, and the rest, about 78%, consists of your quiescent membranes. Your quiescent membranes are the membranes that are actually supporting the retina with oxygen. So at any given point of time, I would recommend, till we have molecules that cause regression and also protect the photoreceptors in RPE, we wait till the sign of activity is my take on it. There could be differences. Why? Because you do not want to remove an oxygenic stimulus to the RPE and photoreceptors provided by this quiescent. When I say quiescent, I mean a membrane that is not going into clinical activity as compared to a subclinical membrane.
Thank you.
I hope people, yeah, okay.
Yeah, I mean, I agree with Uni. I mean, I also feel that that's the way that we should proceed. You know, it is probably supporting. That's why you don't see atrophy occurring. So probably just leave it alone till we really see manifestations of exudation. So I would also do the same thing.
Dr. Uni, one last quick question. See, most of these terminologies like the branching dense capillary network is increasing, the perilesional hypointense halos, and most of these things. So how do we clinically really applicate it? And based on that, should we go? Because the vision is stable. These are the OCTA signs we are seeing. And based on that, should we go ahead with the anti-VEGF injections?
No, I wouldn't. As you said, if you have evidence of exudation on OCT, I mean, that would be your indication to treat. OCTA is just going to be till OCT angiography becomes standardized, reproducible. We are still at a difficulty of interpreting OCTA properly. So seeing a vessel on one slide, not seeing the vessel a month later, we are still not reached a point of time where we can say it is reproducible and standardized. So we still have to depend on the OCT.
Very good. Shall we go on to our next group of debate?
Thank you, Dr. Manvi, madam, and Dr.
Really good it was. We shall now go on to the next debate, which is Juxtafoveal RPE rib, and I want to treat with steroids would be spoken by Dr. Karthike Singh, who's a vitreoretinal surgeon from ASG group of hospitals based at Varanasi. And against the motion is anti-VEGF on the way to go would be spoken by Dr. Sunil Ganikal, who's chairman and medical director of Davangere Netralaya and also professor of the Department of Ophthalmology at Basaveshwara Medical College, Chitradurga. So
I request MPS sir and Ajay sir to please give the final comments for this.
Yes, right. On to you, Dr. Karthik Singh.
Thank you, ma'am. Thank you so much, Chitra ma'am and Dr. Srinivas sir, for giving me this opportunity. I would like to extend my talk with, I want to add steroid in the juxtafoveal RPE ribs. I'll go through my talk now. RPE ribs and in AMD is not very uncommon. We all know about RPE ribs, and I just a small brief, like what are the high risk things are there. Like if there is a large vessel diameter, if you see a hyperfluorescent ring, micro ribs, and a recent PED, all these are the risk factor for the RPE ribs. So what happens in the sudden RPE ribs? There's the drastic visual consequences. There's the contraction of sub-RP neovascular tissue, creating a tangential stress over the overlying RP, and some consider it to be a complication next to only endophthalmitis for anti-VEGF. So prognostication is important. Location of rib is for the prognostication. So what is the dilemma here? Dilemma is whether to continue therapy once the rib occurs. The widely accepted approach is to continue the therapy. So this was a very famous article by David Serous, where he told that continued monitoring of RP tears with the exudative changes warranting anti-VEGF may stabilize vision, improve anatomical outcomes, and reduce fibrosis. So why I highlighted this is because we want to improve anatomical outcome. Not only that, but also improve functional outcome. So this was an image in the same article, and this was a image again from the same article showing the ring sign in the fluorescent angiography for identifying the future rib. So this is the case which presented while I was still in Joshi Eye Institute, and this is the right eye fundus photo where we can see those powdery exudates of proper PCV, and in the left eye there was pachytrusin. So this is a picture which we saw. The RP rib could be very well seen on the autofluorescence here on the other second image, where you can see a hyperfluorescence of on the autofluorescence, and on the treatment it responded really well. But the current follow-up which I got from the people there is this, and I think the further treatment is the wait and watch for this patient right now. So in the era of intravitreal pharmacotherapy, what are we seeing? There is an explosion of reports of RP tear. First, it was identified with pegaptinib, now with almost every injection. So the burden is really high because we are giving anti-VEGF for almost everything now. So why there is a debate? To date, the number of RP tears studied or the length of follow-up has been limited. So what to do, how to continue treatment is the real question. Again, the David Serous article, they quoted that anti-VEGF is the way to go, but does it really affect, does it really do the justice to the treatment? And the relationship between anti-VEGF and ribs has been there. And there is one more the article which says that the anti-VEGF has been attributed to angiofibrotic switch And the CTGF is the factor which is very well responsible for this. This is another article showing the relationship between the RPE RIP and the anti-VEGF. So what next? Do we continue to treat? This is the article. We should continue, and this is the article which says that retinal pigment tear differently depending on the when they occur. Long-term visual outcome in the eye affected by RPE tearing may be related more to the patient response to the therapy than to the tear itself. So we actually treat. So how? I will add steroids. I will add PST or oral steroid, not intravitreal. More frequent half dosing with PST, and started the research also for the same. Thank you, Chitra ma'am, for giving this insight. And I recently treated 2 cases with the same. And systemic, this is the article by one of my senior, Dr. Aditya Sudhalkar, where he said that utility of systemic steroid in the patient with CNVM RPE tear with SRF, which was recalcitrant to intravitreal or anti-VEGF, but responded partially to systemic steroid. This is another article by my senior, where he showed that the steroid was beneficial for these patients with large PED. And this is the image from the same article. So this is one of my case, which I went back and searched that whether I treated anything like that. And this was a case where the lady, a 62-year-old female, presented with 2/60 vision since long, multiple anti-VEGF in the past. This is a fundus photo. And this is the OCT I wanted to show. And there was actually a rib which I could identify on fundus fluorescein angiography. Somehow I lost the data. Sorry for that. And I added PST in August, both the eyes. So this is what I got. The vision actually improved to 6/36 and 6/24 in left and right eye respectively. And second dose of Avastin with PST was given again. The patient was really poor, so I could give only Avastin for this patient. And after follow-up of 1 month, the VCA was really 6/24. And this is the final follow-up of 6th November, the recent follow-up. I could see some early ORTs in the left eye. Otherwise, I thought some IRF was there, so I thought to continue treatment for the left, and right eye is under observation. So what I learned, adding steroid not only helped with anatomical success, but significant functional outcome. More cases and detailed research with analysis is already on from my side, and I would love to present such cases in the future. Thank you so much.
Thank you. Thank you very much. And a wonderful debate. On to the next speaker.
Yes, ma'am.
Sunil, yes.
Yes. Is my screen visible, ma'am?
Yes, yes.
Okay. Because let me put my point of view regarding the why I want to continue with anti-VEGF. And Karthikeya, just a minute.
Yes, sir.
Can you do the slideshow mode and then?
Yeah, it's okay now.
Yeah.
Okay. Yeah. Why anti-VEGF? Karthikeya definitely agreed with me that anti-VEGF has to be continued. Now the question is whether to treat with his argument was the topic given to us whether to use only steroids or steroids with anti-VEGF. One thing we should remember is the cause of RPE RIP is multifactorial. So steroids alone you cannot consider. And the CNVM activity continues even if after the development of the tear. Why we thought of steroids is, as we know, in AMD there is an hypothetical that scenario saying that inflammation could be one of the plays a role in the pathogenesis of AMD. One should keep also in mind that various disorders also contributes for the RPE tear. So one should use the steroids with caution. What are the concerns with steroids? He showed about the using the steroids. I do agree the intravitreal steroids may not be the thing. You can use systemic steroids or the post-receptinals. But the thing is no standardized treatment protocols. How much steroids to be given, how long to be given, depending upon the size of the PED or where the tear and other things. Another thing is most of our patients are old patients. They tend to face adverse effects with the oral steroids. So even the literature says that oral steroids can be used as an adjunct to anti-VEGF. It helps in the resolution of the SRF as well as it reduces the PED and makes the disease more responsive to anti-VEGFs. But steroid-only treatment may not be the option. The studies also have shown, various multi-center trials have shown that ranibizumab shows better visual improvement if you continue with the anti-VEGF therapy. The studies have also showed that up to 2 years, you will get almost 87 to 90% stabilized or improved best corrected visual acuity if you tend to continue an anti-VEGF after the RPE rip. So even with spontaneous RPE tears, treatment with anti-VEGF has shown beneficial effect. Studies have also shown a functional improvement as shown by microperimetry or morphological changes on OCT after anti-VEGF. There has been shown to be reduction of SRF, IRF, and anatomical restoration. But my only concern is a continuation of anti-VEGF has been there's a question mark in the cases associated with multilobular tears. Many have advised the cessation of injections if there is a multilobular tear, but unilobular tears, definitely you can continue with the anti-VEGFs. Let me show some of the cases where I continued the anti-VEGF therapy in spite the post-anti-VEGF RPE tear. Here, after 3 months, you can see the stabilization of the PED has been reduced, the anatomical restoration has been done, even the SRF has been reduced after the continuation of the anti-VEGF therapy. As Karthikeya rightly pointed out, you should know when to add steroids to your anti-VEGF therapy when continuing with after the RPE rip. It is a similar case which has been treated with the combined modality of treatment. After 3 injections, there was still recalcitrant or refractory SRF and the persistent PED. Steroids were added, so you can see the resolution of the SRF and the PED has been reduced. This is another case which responded very well to RIP, responded to anti-VEGF. So my take is, after TF formation, look for the active disease process. Anti-VEGF should be continued. Anti-VEGF injection gives a positive final visual acuity and anatomical respiration and prevents fibrosis of the CNVM. Multilobular tears, definitely you can avoid it, but if it is an active disease process, sometimes you can think of reducing the dose and other things. What cases Karthikeya showed are the more of a PCV cases. So PCV cases, definitely the contractile changes are less when compared to the AMD. So definitely you can add steroids in PCV cases, but when AMD with significant contraction, one should be very careful in continuing with this. Steroids can be an adjunct, especially in refractory and non-responder cases. The most important critical thing in patients with RPE RIP is the gap between when you initiated the anti-VEGF treatment and when the RIP has occurred. Whatever the modality of treatment, if it is more than 6 months, patient may not develop good visual prognosis. So my take is you should add the steroids at the right time and to get an optimal outcome. Thank you. Thank you for your patient hearing.
Thank you. Very excellent debate, both of you. Very energetic too. Dr. Srinivas, can you take the questions?
Yeah. Yes, sir, and then MPS, sir, please.
Yeah. So I think both have presented pretty well. What was the topic given was a juxtafoveal RIP. I think that indicated that when the fovea gets involved, by Saraf et al., what they have said is that is, by prognostic point of view, is a grade 4 category. You know, they are divided into less than 200 micron, 200 to 1 disc diameter, more than 1 disc diameter. When the fovea is involved, it's grade 4. It's very important to remember that in case the RP RIP involves the fovea, if you're given the patient an anti-VEGF, that has caused an RP RIP, it becomes very difficult to tell the patient that I'm going to give you the same injection, the one which has already caused the RP RIP. So that person has to be convinced that the disease is not over. This RIP would have occurred in the absence of an injection also spontaneously. Therefore, the injection is important. And what we are trying to achieve and what Karthikeyan is trying to achieve is invariably between the retina and the choroid capillaries, a fibrous plaque sometimes forms, which is the cause of diminution of vision over a period of time. And there, if the fluid is not reducing with anti-VEGF continued injections, then maybe steroids can be added. The reports at the moment with systemic steroids or with steroid use is not very convincing. There are no large studies because the RP RIP itself is not so common, though the incidence which is given is almost about 14 to 19%. I personally had only 2 cases in so many years of an RP RIP occurring. So over to Dr. MPS for additional points.
Thank you, both of you, for presenting very, very well. I have not specifically used steroids in the presence of an RP RIP, but more in PCV patients which are recalcitrant. So my take is, if there is, during the course of treatment, if there is intraretinal fluid, I may use only steroids. If there is intraretinal fluid and steroid and subretinal fluid, then I may add both together. So that's how I go about it in resistant patients to only anti-VEGF. In the presence of RP RIP, yes, I would continue using the anti-VEGF agents. But then steroids, whether I add or not, I have not much of personal experience to talk about that.
Sunil sir, you added one point. In PCV, you said the less of contractile property, AMD is more of contractile property, and if the contractile property is more in cases of these rips, and still you want to go ahead with anti-VEGF, is that what you were telling about, sir? I didn't get that point clearly.
The fibrous component will be less. So the rip progresses because of the, if you keep on injecting anti-VEGF for further fibrosis, for especially juxtafoveal tears, it may worsen worsen the scenario. That's the reason.
See, Srinivas, another point which is important to remember is, whenever we face patients like this, we talk about the size longitudinally, the height as a prognostic factor, and we also talk about whether the PD here is recent or old. Usually in a recent PD, the chances of contractile is much more than in an older PD, not because of the fibrous component, but because of the CNVM contracting earlier in a fresh PD with a CNVM. It's inversely related.
Shall we go on to our last debate,
Yeah. Thank you, Sunil sir. Thank you, Dr.
Thank you, Srinivas. Thank you, madam.
Thank you very much. So we shall go on.
I request Hemant Murthy sir and Dr. Unni to please give the final comments for this video.
We shall go on to the last set of our debates by Dr. The topic is scleral tear with detachment, single stage, and Dr. Jayanto Shekhar Guha would be talking on it. And he's currently is a senior consultant and CEO of Sai Retina Foundation at Delhi. And he would be argued against by Dr. Mayank Bansal, who's going to talk on two-stage surgery, and he's a vitreoretina consultant from Fortis Memorial Research Institute, Gurgaon. On to you, Dr. Jayant.
Thank you, Chitra ma'am. Is my screen visible to all?
Yes, sir. Yes, sir.
Thank you. So the topic is scleral tear with RD single stage, as it should be. Now, the detachment can accompany both open and closed scope injuries, but it's mostly with the seen mostly with the closed globe injuries, and around 30% with the open globe injuries. And of course, there is foreign body is associated with 6 to 30% of detachment. As you can see, a foreign body being removed. First, it is oriented longitudinally and then removed. Now, so here is just one example of a pellet removal, which I want to show, which I was alluding to earlier. We were using in those, this is a 2010 movie. We were using the Calazian scoop. Of course, now in the bottom screen, I won't go into it. I will skip that video. We are using Manish Bapa's forceps. So these are the signs. I'll skip a few slides due to paucity of time. Signs of an open globe. Sometimes it is revealed and sometimes it is occult. Now, there is another example of such a case, and the presence of an intraocular, the investigations are limited. The people, if they have recourse to CT scan, they go. B scan is controversial in these cases, as it's an open globe. But the best examination, they say, that overrides everything is a surgical exploration. Now, in what is known, we have to do first attain a watertight closure of the scleral wound, as is shown in this video, by following the 50% rule and also the close as you go rule. And after making it a watertight incision, I also do a depression test to ensure there is a watertight and it stands the test of scleral depression. Now, the intraoperative scleral rupture also occurs, by the way, during VR surgeries and also during any sort of injections like silicone oil, strabismus surgery, and PFCL injections. So just for one, I want to stress that while injecting anything, I use a bimanual technique with the other eye, making a vent like as you see in this video. Just a quick, so one eye injecting, and I routinely do it. And with the other eye, carrying a soft tip cannula or a cutter, providing active suction or a passive suction. Here's an example of a scleral rupture, so which, as we all know, is primarily repaired. We don't wait for a second stage when it happens during retinal surgery. So once a globe rupture occurs, it leads to a vigorous healing response that can lead to additional injury. The purpose of treatment is to break the cycle by primary repair.
1 minute left.
Now, yeah. So I'll just go. There is a horde of literature to suggest that it is the primary repair which is the early past is of benefit in rupture cases. So the accelerated healing process can be interrupted to vitrectomy carried out in time. The advantage of vitrectomy, we all know, is removal of the blood and other pathological stimulus of wound healing, including the scaffold, the proliferating cells, and serum products. I stated so as to prevent a picture like this at the end if we delay the repair. So I'll just keep a few slides and straight go into the video. So this video, the main difficulty they say in PVD induction, especially the young. So we use a host of methods, as you would see, a bimanual technique using forceps, cutter, a combination of everything to create a PVD and get on with the surgery. And the critical issue is also in these patients of cleaning up the vitreous base and removing all traction around the retinal tear, as you would see. So, and I'm coming to the last two videos. So then if we can, the other technique that I use is to inject the dye under PFCL because often these are accompanied by traumatic macular holes and peeling the membrane. And so at the end of the surgery, as is shown in the last video, we do endolaser and then we put oil so as to ensure complete retinal reattachment and benefit to the patient, which otherwise would result in a severe PVR reaction. So in conclusion, it needs an experienced surgeon to do a primary repair after a watertight scleral suturing, after a depression test, which standing as test of depression. And in order to break the cycle of accelerated healing response and to save the eye from disaster sequelae, it is always a primary intervention, which is the order should be the recourse to be adopted by experienced surgeons. Thank you so much.
Thank you so much, Guha sir. You have made your points very well. And now I request Dr. Mayank. You can unmute yourself, Mayank. Are you muted, Mayank?
Yeah. So at the outset, thank you so much, Dr. Chitra and Dr. Srinivas, for inviting me for this. I'll straight move on to the presentation straight away. So just starting off with the video. Can you see the video?
A very good evening, everyone. I'm Mayank Bansal, and I'm speaking on scleral tear with retinal detachment, two-stage surgery. And while I discuss about this topic, I'm sharing two cases, patients with having scleral tears and retinal detachment whom we manage with a two-stage surgery. Herein I'm showing a patient who had incarcerated retina and both the tractional as well as rhegmatogenous retinal detachment component. And underlying the retinal detachment, there was this large intraocular foreign body which was actually adherent to the courts. So after doing a relaxing retinectomy here, I used first intraocular macronate. It could not come out, so I had to use the intraocular foreign body holding forceps and apply a significant pull to take out the foreign body. And that actually brings me to the first point I wanted to emphasize on, that how a two-stage procedure helped us in this case who have intraocular foreign bodies, and we were to consider operating them in a single stage. There's a very high chance that while removing such a tightly adherent foreign body, there's a possibility of the wound gaping and leaking, having a hypotony while operating, as well as encountering a lot of intraocular bleeding while doing the vitreoretinal surgery. And if we were to try and increase the eye pressure, the wound may gape, there will be significant bleeding, hypotony. So all of these things are avoided by doing a two-stage procedure, which we have done in this case. And after removing the foreign body, I released all the traction, injected perfluorocarbon liquid, did a air fluid exchange followed by a PFCL air exchange. And then at the end, I'm injecting triamcinolone to prevent chances of PVR. And another case here that I'd like to emphasize similarly is who had intraocular foreign body as well as retinal incarceration with retraction, detachment. And after clearing the vitreous hemorrhage, we noted that there was this very tightly adherent foreign body at the posterior pole, and removing it had significant amount of bleeding. There was a tight fibrous capsule. There are definitely demerits of doing a two-stage surgery. These would mean that we are delaying the retinal detachment surgery in case of doing a two-stage procedure, which increases chances of more PVR formation, more fibrous ingrowths, and may overall decrease the visual prognosis of the patient. Overall speaking, various factors may help us make the decision as to go for a single or two-stage procedure. Among them, size of the wound is a significant factor. Location of the wound. So large wounds which are likely to gape, a two-stage procedure probably makes more sense. Smaller wounds which are likely to gape, we can perhaps consider doing a single-stage surgery. And the location of the wound, for example, zone 2 wounds which are closer to the limbus are likely to have fibrous ingrowth. So perhaps an early retinal intervention makes more sense. Intraocular foreign body, a two-stage is preferable, is more desirable, whereas in cases of infection in the eye, a single-stage procedure would be more desirable. In this case, we see how while removing the foreign body, there was significant amount of bleed, which I controlled with both increasing the eye pressure as well as injecting in perfluorocarbon liquid, after which suturing the wound back again and releasing the traction to settle the retinal detachment by doing a relaxing retinectomy, and then following it up by doing the retinal laser and injecting silicone oil. To summarize, there is no cookie cutter technique. There are very varied presentations that patients have in such situations. There are pros and cons of both ways, and perhaps using the above discussed points gives a good direction for us to follow in situations like these. Thank you for your patient hearing. I'm very happy to take any questions now.
Yeah. Very well, nicely presented, Dr. Mayank and Dr. Moha sir. Yes, sir. Hemant sir, your thoughts?
Yeah, I think both of them presented, gave points which would probably say whether you'd like to do a single stage or a two-stage. I know I think Jayant was very clear when he said that you would like to avoid, this proliferation, fibrous ingrowth that occurs and fibrous proliferation that occurs. But that is basically if you delay the second surgery. Generally, the best way is to do a watertight closure because there is an advantage. The wound heals and then you get a very stable sclera when you do a two-stage procedure. There is less chances of bleeding, which was pointed out by Mayank. And also PVD induction occurs, so that PVD induction becomes easier. But the size of the wound will also tell you whether you would like to go for a one-stage or two-stage. So all these factors are probably there. One cannot say that you're going to do one. I think both of them had points for both sides of the story. So I think individually, if you individualize the case, there could be a strong points for either of them. But generally, the second surgery, if it is done in two-stage, should not be delayed more than 7 to 10 days. That's the dictum.
Yes, Dr. Unni.
I think Dr. Hemant has made a great point. All I'd like to say is that the point of primary repair surgery is primary repair. So the getting a closure of the ruptured globe would be the most important thing in that particular surgery. Now, if you have such a great view of the retina and you see it is detached, that naturally indicates that probably the entry wound is quite under control, and you may. So, as Dr. Hemant said, it all depends upon your preoperative evaluation. The presence of blood would accelerate all these fibrotic changes inside. So your decision, but the gap
as he mentioned, between the primary and second time you go inside would be a very important thing. Modifications, if you feel that there is a high chance of endophthalmitis happening by the nature of the foreign body that has gone inside, you may have to be more aggressive in your primary approach and things like that. So yeah.
Thank you, Dr. Oni. MPS sir, I had one quick question. In cases where you saw that Mayank put out that foreign body, and in sometimes there can be a choroidal tear also along with that. And in some cases, I have seen one of your videos that you use silicone sponges. In which case do you really attribute using that? Because there is a chance of the silicone oil also going into the suprachoroidal space and causing in more detachment. So are you still doing that, or how can we address these kind of things?
The video you're speaking to is from my colleague, Dr. Rajesh. That was like, again, in the acute phase when the patient was taken up for the surgery and the foreign body is removed and the posterior scleral opening was there. And whatever we put inside was escaping outside. Perfluorocarbon air was escaping outside. So in that situation, we used a silicone sponge to plug the posterior scleral defect so that the integrity of the globe could be achieved. So that is the situation when we would use. Otherwise, yes, we would want to take it as a stage procedure. The question is like the visualization. So wherever we are able to achieve a watertight closure and visualization is possible, then we can attempt to do the surgery at the initial sitting. But the issue is PVD induction can be difficult in the initial sitting. So that's going to be an issue. So the fact for a primary surgery is if there's a foreign body and risk of an endophthalmitis, yes, then we can probably do both together at the same time if all of the circumstances permit.
Yes.
Ajay sir, last comment and we'll close.
No, I think I agree with whatever has been said. If there's an associated lens injury, then I would prefer that we do the scleral tear repair and clear up the lens, get a better visibility, and do the retina at a second stage. Because that would allow me to, and not put in an IOL if I'm expecting a foreign body and go in quite rapidly, within the first week itself. If there is a chance that if end-off is likely to occur with the intraocular foreign body, depending on the type of foreign body, I would probably do it at the same sitting itself.
Sir, you mean to say that you want to do a lensectomy in the first stage when you are talking about this?
Not really. I think I have got a very good anterior segment surgeon with me. So, my wife, she does a very good cataract surgery. So I would probably respect her. And in case we can manage a phaco in such a situation, we'll go ahead without putting in the lens, not a lensectomy.
Okay, nice. That was very well summed up. And I think it has been a wonderful evening. Like, it's unimaginable how the whole sequence of event moved on, and the kind of learning and the discussions, contribution by the expert panel was just mind-blowing. And they say attention span. Imagine an anterior segment surgeon, my attention span was so superb that I didn't move a second from the whole thing, At least temporarily, I'll remember everything. So that tells how amazing the speakers were. Hats off to all the speakers and the expert panel for so much of energy which you gave to this webinar. And I would be so failing in my responsibilities if I don't appreciate how wonderful my moderator was. Srinivas Joshi is just truly a young, dynamic, fantastic ARC team player of mine, and he was ably helped. We have to bring it to attention. He was very ably helped by Dr. Giriraj Vibhuti and Dr. Rajshri Salvi in making this program together. And I really never anticipated it would be such a good program. And of course, I need to thank the AIOS team headed by Kripal for the SMS which they sent and helped me go forward. I need to really thank Sai and Manjula from Numerotech for sending all the mailers to you. And my thanks are due to my young friend of ours working from a hospital, Vel Murugan, who has always helped me a lot. And you would be shocked if I tell you the hours which ARC work has become nowadays, which might be a deterrent for many people to become ARC chairpersons. And that is the kind of help he has given me. And finally, and most importantly, I need to thank our webinar admin and Mr. Sunil and Entod for being my sole sponsors for the last 2.5-3 years. And most importantly, thank you very much, delegates. I'm sure the numbers are going to be good, and Mr. Sunil will definitely update all of us. And thank you, one and all. 3 cheers to all of you for a wonderful 2.5 hours.
Thank you
so much,
Dr. Chitra. It was wonderful. Nice meeting. Thanks, Srinivas. Wonderfully moderated by both of you. I think being an anti-segment surgeon, you've had so much of interest. That's hats off to you.
Yeah, that talks volumes over the quality of the webinar.
By the way, Srinivas is also becoming an anterior segment surgeon with the ASMICs.
He's
that part is over now. Let's not go back. It was a responsibility given to me, and I just carried over.
That's very good.
Thank you, sir. Thank you very much, all of you.
Thank
It was really an enriching.
you for stepping in last minute and doing so well.
Thank you, all of you.
Thank you.